And hello, everyone. I'm Michael McNutt with WEDI, and welcome to Federal Policy Consultation, X12 version 8060 HIPAA electronic transactions. It's my pleasure to introduce WEDI's Executive Director, Rob Tennant.
Thank you, Michael. Let me add my welcome. This is a very important event. We are here to talk about the potential adoption of the X12 version 8060 HIPAA transactions. As you all know, it's been many years since the industry implemented version 5010. And so we're gathered here to discuss and hear from experts on some of the benefits and costs and other related items related to potentially implementing this new transaction set. Next slide. So just an overview of today's agenda. I'll be followed by Pam Grose to discuss the FPC process and how it was developed. We'll then turn it over to our colleagues from the Centers for Medicare and Medicaid Services. Then we'll hear directly from X12 regarding the development of this new version of the transactions. And then we'll get into our panels. At the end of the program, we'll have an open opportunity for attendees to weigh in with their thoughts on today's topic. And then we'll do our wrap up and discuss next steps. So for those that aren't familiar with our organization, I wanted just to take a couple of minutes to introduce you to the Work Group for Electronic Data Interchange, better known as WEDI. We were formed a long time ago, back in the early 90s, by then HHS Secretary Dr. Lewis Sullivan, a practicing physician who knew firsthand some of the challenges that providers and health plans face in trying to exchange health data. So he created what he called the Working Group for Electronic Data Interchange, made up of some of the leading figures in healthcare at the time. And he charged them with drafting reports that would outline a new approach to data exchange, leveraging standardized transactions, code sets, and identifiers, at the same time developing privacy and security guardrails to make sure that when that data was sent electronically, it would be kept confidential. WEDI, then those two reports were folded into legislative language, which became what we know as the Health Insurance Portability and Accountability Act, better known as HIPAA. WEDI was named in HIPAA as an advisor to the department, and we've served in that role ever since. We've got very strong working relationships with CMS, with the Office of the National Coordinator, ONC, and with the Office for Civil Rights, OCR. Our mission is simple. We advocate for more efficient standards and secure data exchange. We have a multi-stakeholder membership, including health plans, health plan associations, providers, provider associations, clearinghouses, supporting vendors, all of the major healthcare standards development organizations also participate in WEDI, as do CMS and ONC, both serve on our board of directors. And finally, we've gotten a number of patient advocacy groups to be involved in WEDIs, which really allows us to have the patient voice front and center. If you go to the next slide. So when I think of WEDI, I think of two words. I think of us as a convener and an advisor. And as a convener, we have more than 3 dozen educational events a year. Our work groups, which I'll talk about in a second, produce guidance and fact sheets and education for the industry, not only on what the standards are, perhaps even more importantly, how to implement those standards. And as an advisor, you're part of this federal policy consultation process. We also have a member position advisory process, which is put into place to respond to propose rules or requests for information. And those lead to consensus-based comments and letters going to CMS and other agencies. And again, a big part of what we do is to bring the industry together to solve problems and advise the federal government. So our WEDI in action, education, collaboration, and advisory. You can see here we've got number of conferences, webinars. We have special spotlights on important HIT issues. Very popular podcast called The Collective Voice of Health IT. We've got a number of member-only events, and we also feature sponsored events as well. We've got 17 work groups, sub-work groups, and task groups, which cover most of the HIPAA transactions, but also issues like genomics, privacy and security, emerging technology, the No Surprises Act, and others. And as I said, as an advisor, we work directly with a number of the federal agencies to provide industry input, as we'll do following the event today. So with that, it is my pleasure to turn it over to my colleague and friend, Pam Grose. Pam is on the WEDI Board of Directors. She's also our Vice Chair of Policy, and she co-chairs our Remittance Advice and Payments Sub-Work Group. And Pam, again, thank you for your leadership in developing WEDI's FPC process.
Thanks, Rob. Let's talk about how we developed that and what it looks like. And the slides just went away. So we'll wait one moment. Thank you. All right, so as Rob previously mentioned, we do have already had a member policy advisory process, but as we started looking at some of the new regulations coming out, it became apparent that we needed an additional process to support gathering information about the different regulations that were coming out. So we determined that there was a need to support HHS and other agencies by proactively convening consultation events prior to any regulatory action, and that activity needed to include people that were, or entities that were beyond the WEDI membership. We wanted to include all of the healthcare industry. So the purpose of the Federal Policy Consultation process is to gather information on topics for potential regulatory actions, convene industry stakeholders to collect feedback and data, and then compile those industry perspectives and recommendations and provide all of that to HHS. So the way that we're doing that, maybe through some or all of these processes, we may conduct surveys, we may hold meetings or hearings, we may have requests for written statements, we may do interviews, we may have electronic polling tools that we use, and other relevant means. So we may use some or all of those tools in order to gather information from the industry to report back to HHS or the industry or the entity that is requesting the information. And the output of the Federal Policy Consultation process is a report on the input that we've received, and we submit that to the agency, and it's also made public. Next slide, please. So for this Federal Policy Consultation process, there's a couple of ways that you can participate, one of which you're doing right now by participating in our meeting today. We also have a survey that has been sent out, and it closes Friday, April 24th. So everyone has the opportunity to respond to the survey and provide your input there on the potential benefits and costs of moving to the HIPAA version 8060. And you also have the opportunity to submit a written statement through an online portal, reachable through the link on this slide. That also closes Friday, April 24th. that gives you the opportunity to provide your input on updating the HIPAA transactions to version 8060 in written format. Next slide. So after we conclude this FPC process, after April 24th, when we not only conclude the survey, but also the opportunity to submit written statements, WEDI will compile all of that data that was received from the survey, the submitted written statements that were put in through the portal, the testimony from the panelists today, and any comments from the FPC attendees today. All of that will be compiled, and WEDI will draft a report summarizing that information that was obtained, and we'll submit that report to CMS, and the objective is to do that in early May. So WEDI is not providing the opinion of members. That's done through the MPA process. WEDI is compiling information from the industry and submitting that to CMS. Once that is done and the report's submitted, CMS will decide on next steps with version 8060 and follow up with any potential rulemaking. So now I'll turn it back over to Rob to talk about opportunities to share your perspectives today.
Thank you, Pam. And again, thank you for your leadership. This is a unique opportunity for you to offer your perspectives and recommendations on whether or not the industry should move to this latest version of the HIPAA transactions. If you go to the next slide. We want to start by saying you can put whatever perspectives and recommendations you have in the chat. You can also ask questions, which, if possible, the panelists may be able to answer. I will say, please obviously be professional when asking your questions and posting comments, and know that we are capturing everything in the chat, and we will include it, if possible, in the report. But know as well that we will not be attributing any comment, whether it's through the portal, through surveys, through the chat, or if you speak, we will not be attributing those comments to any individual or organization. So we keep those out of the report. We are simply reporting what you said, not who you said it, or who said it. So go to the next slide, please. And around 2:40, depending on how the panels go, we expect it to be around 2:40. We will open up the mics to individuals who want to make a comment. You will be asked to raise your hand, and then you'll be unmuted, and you'll be able to either ask your question or make a comment. We do ask that you limit your time to just two minutes. If you've got additional comments or questions, you can get back in the queue, and if there's time, we'll be able to get to you. You can continue to use the chat feature during this time as well to ask any questions or make any comments. And again, we just thank you in advance for being professional when asking your questions or making your comments. And with that, it is my pleasure to introduce Michael Cimino, who is the director of the National Standards Group at CMS, and Chris Wilson, who is senior health insurance specialist at CMS. Thank you, gentlemen, for being here and being part of the FPC.
Yeah, thank you, Rob, and good afternoon, everyone. I just want to say thank you to WEDI for pulling this session together, and that we really appreciate all of you coming together to provide information and feedback on version 8060 for the HIPAA mandated transactions. And of course, I know I've probably said this before, we take your input very serious, and it greatly informs our rulemaking efforts, not just because statute requires that, but really industry advice. Your feedback is what sets our priorities and drives our work. I can't underscore that enough. So we're excited to hear from you today, the positives, negatives, the costs and benefits, and any information that you feel would help us best meet your needs through the HIPAA standards adoption process. So thank you all again, and I'm going to turn things over to Chris Wilson from my team to talk a little bit about our regulatory standards adoption process and how that works. Chris?
Yes, thank you, Michael. And if I can I share my screen? I'd like to share some slides for you.
Yes, you
Give me
can.
1 second. All right, can you see that?
You're good to go.
Good, great. So again, my name is Christopher Wilson. I'm a senior analyst here at the National Standards Group within CMS. Um, and within CMS, our role extends beyond CMS programs. We actually have oversight of HIPAA administrative simplification standards across the entire healthcare industry. And that means we're not just working with Medicare or Medicaid providers and plans. We are working with providers, health plans, clearinghouses, and vendors across the country who conduct electronic healthcare transactions. And so today, I'm going to just briefly walk through not only what administrative simplification is, but also importantly, how we develop policy, how we engage stakeholders, and how we um, do our rulemaking from start to finish. And so, at a high level, administrative simplification or admin simp is about standardizing business processes and how information is communicated across the healthcare system. And the idea is simple. If transactions are conducted the same way between entities, using the same structure, the same data elements, and the same language, it'll allow for automation and it will reduce manual work and improve its efficiency. And so HIPAA provides that framework for doing this. And one thing I always like to clarify, especially when talking to technical audiences, that HIPAA is not a technology. And that also, even though it was passed in 1996, it's not something that's outdated. It's actually a legislative framework. And that defines how the standards are developed, adopted, and maintained. And that framework is designed to ensure that stakeholder input is incorporated throughout the process. And so you'll see here who is covered. You'll often hear the term HIPAA covered entities, and that includes the healthcare providers who conduct transactions electronically, health plans, and clearinghouses. And many of these entities also work with business associates. And when they do, those relationships must be governed by contracts that require compliance with HIPAA standards. And so when we talk about HIPAA compliant transactions, there are 4 key components. The first is the implementation guide, which defines the structure and required data elements. The second are code sets, which you probably already know. They standardize how things like diagnosis or procedures are represented. Then there are unique identifiers like the MPI or the tax ID number. And then there's the operating rules, which define the business processes around those transactions. And each of these components play a role in ensuring that transactions are consistent across the industry. And importantly, each of these components may involve input from different stakeholders, which is why coordination and engagement is very critical. And so here you'll see a high-level timeline of admin simp. As mentioned earlier, HIPAA was enacted in 1996. In 2000, HHS adopted the initial standards and code sets. In 2010, the Affordable Care Act expanded requirements, including the mandate for attachment standards. And then in 2011 and 2012, we saw the first operating rules adopted. And that's important to note here that the framework has been in place for decades, and updates to standards have historically taken time, often several years. And that timeline is one of the key reasons we're focusing on modernization today. And so this slide reflects the list of transactions and statute for which the secretary may adopt standards. And that's something that's very important because we don't necessarily adopt one standard for all transactions at once. Instead, we evaluate what standard is appropriate for each transaction. And this is where stakeholder input becomes crucial as well, because we need to understand what works operationally, what's feasible, and what meets industry needs. And so it's not a one-size-fits-all process. It's very much driven by feedback and real-world use cases. You'll see here how standards are adopted. It really gets to this slide really gets to the core of what was requested today. You'll see first, the standards are developed by the standards development organizations like X12 or HL7 or NCPDP. These organizations are industry-driven and include stakeholder participation, as you all are aware. Second, the standards are reviewed by NCPHS, which provides formal recommendations to HHS. And then third, based on those recommendations, HHS engages in rulemaking to adopt the standard. And so rulemaking itself is a structured and transparent process. We first develop a proposed rule, we publish it, and then we open it up for public comment. This is one of the most important points of engagement because stakeholders can provide detailed feedback on everything from policy decisions to technical specifications. And then we review and analyze all of those comments, which is often hundreds or even thousands, and then we use them to inform the final. And so then when we talk about stakeholder input, it's not just something we consider, it's something that we formally build into the regulatory process. And then next, you'll see how we determine the changes to those standards. When it comes to updating standards, there are three categories. There's the code set maintenance, there's the standards maintenance process, and then there's full modifications. And the key distinction is whether the change is minor or administrative, or substantive enough to require rulemaking. And again, stakeholder input plays a key role here, mainly in identifying when standards are no longer meeting industry needs. And then out in here, I think that was the gist of the presentation or the information requested. And I'll send it back to you.
Thank you, Chris, and thank you, Michael, for that overview. At this point, we will turn it over to X12. Oh, Chris, do you have more
No, I'm
slides you
sorry.
wanted to cover? No,
Just
okay.
trying to figure out how to get share the screen. Sorry about that.
Okay, great. So I think we're ready for Andrew from X12. And Andrew, the floor is yours.
Probably be better if I unmuted myself. Thank you. Can everyone, you see my screen okay, Rob?
We did. I think we just lost it.
Just 1 second. There we go. How's that?
Excellent. Yep, you're up.
Great, great. Well, first of all, thank you for the opportunity to speak on behalf of X12 today. We're going to try to keep this as succinct as possible. There's a lot we'd love to talk about, and we have some other forms we'll reference near the end of our section here. If people would like to learn more about these new versions in some more detail. First of all, and this is X12 standard disclaimer. This presentation is for informational purposes only. It's not obviously legal advice, and it's point-in-time information. That the content and the subject that we're going to talk about is subject to revision, especially when it comes to the tools that X12 is in the process of providing related to the 8060 version. First, I'd like to give a little bit of background on X12 as an organization. And for those of you, I would hope most of you are already familiar with this, but if you're not, here's a quick spiel about it. It's we have X12 is a handful of staff, probably about a dozen full-time equivalent people. We've got hundreds of members and thousands of member representatives, and I'll talk about the difference between that in a second. The members include So corporations, stakeholder associations, other organizations, government entities, and individual members in some cases. One of the, I think, the unique things about X12 is who makes up their membership. It's, I would say, expertise in most of the participants that contribute to the development and maintenance of these standards are people that use these standards. So it doesn't happen in an environment where we have a think tank of, hey, what could we dream up that might be interesting? It is people that roll up their sleeves and use these standards for their, and in most cases, their employers' benefit to, with the whole goal of administrative simplification, removing friction for data exchange between trading partners. This is just an illustration of X12's organizational structure. And as you can see, by design, it is hierarchical. It is obviously member representatives, and all of these positions are considered volunteer positions. The board of directors, in fact, is voted on by the member representatives as well. We have the accredited standards committee on the left-hand side. That standards committee works on what X12's ANSI accredited standards development. And I'm not sure if everyone's familiar with ANSI accreditation. It's really important to X12. By being accredited by ANSI as a standards body means that you have met some basic fundamental operating principles. You live up to your operating principles, as well as your consensus process you use to develop these standards is balanced. And you follow your procedures for doing that, and then it's accredited by ANSI. X12 has a governance panel in the middle, and then on the right-hand side is also important X12. It's called the Registered Standards Council or Committee. This is not the X12 transaction standards. These are things that are somewhat related. So external code lists. Many people are familiar with some of the code lists X12 develop and maintain. And that would fall under the Registered Standards Committee for how they maintain and when they're updated and so forth. As I mentioned before, there's hundreds of members and then member representatives. Typically, a member would be a member company. And then that member company would have representatives, or in some cases, several representatives that are representing their interests and participating in the ongoing development and maintenance. We have three different types of representatives. The primary representative, this is the person that is the primary contact for that member company, that ultimately are generally the person who will cast the ballot, a member ballot, for the final approval of an X12 work. An alternate representative, which would essentially an alternate to the primary, and then the other member representatives are just called designated representatives. There's a little bit, and this is maybe a plug, but what it means to be a member is you're representing your company's interests in an antitrust-friendly, consensus-driven form. When it comes to X12's transaction sets and standards, it is ANSI accredited. So having balance is really important to us in what we do, but it's important that it's an antitrust-friendly environment as well. You can influence change, obviously, with new versions or updates to existing versions, even including code sets that are external to the transactions. And then obviously through X12's meetings, you network with decision makers and other professionals. The membership, again, is largely made up of people that roll up their sleeves and do this on a everyday basis in their regular job, and then participate with X12 to represent their companies and their interests. So if you want to, and when you get a copy of these slides, you can review the membership categories online and then apply to become a member if you are interested. One last thing, and I'm not going to read the slide, but I think it's an important consideration when we think about not just the breadth of what X12 has done and continues to do. It also includes the reach. So billions of transactions are exchanged daily using X12 standards. And this is not just in the healthcare industry. Most of us are familiar with, claims, payments, eligibility, all of the other related transactions, but also in supply chain transportation. If you were to purchase a product from a retailer, pretty well any retailer in the United States, behind the scenes, there is an X12 transaction related to that. that is handling that exchange between manufacturer to supplier to retailer. And they're used extensively and have been for more than 40 years. The reality is that most of these transactions and are not just well utilized, but established infrastructure that has been around for a while. Technology developments and the evolution of technology, I think, is given a great opportunity for implementers to implement some of these technologies and extend them at a lower cost. But it's important to understand, I think, and recognize that these transactions work. They often don't get the credit for how much these transactions, how much data these move in a standardized way across every industry, including healthcare and insurance. Okay, I'll talk a little bit about X12's maintenance request process and its annual release cycle, because I think it's also an important consideration that many people don't understand. So we call it the ARC, or the annual release cycle. X12 is full of acronyms, the MR meaning and maintenance request. The idea being behind this, and it was born from feedback from different industries, including largely the healthcare industry, related to, I think, what was used to be referred to as predictability roadmap, in that X12 will kind of change its process to have a more predictable schedule for updated versions. Historically, and as a lot of other standards bodies work, new versions are released when the scope is complete. So the scope will drive the schedule. X12's annual release cycle is different in that the schedule will drive the scope. If the scope, meaning a maintenance request, gets through its process within a year, it will get into that next release cycle, which will be the next year, and so forth. The release will not be held up or stalled in some cases because a piece of a new maintenance request has not been implemented or appropriately vetted through X12's consensus-based process. So this is just illustration. I want to make sure I mention that the step one in this process is a suggestion. Anyone from the public, you don't need to be an X12 member to submit a suggestion for an update to an X12 transaction, or the potential for a new transaction to meet a new business need in an industry. Anyone from the general public can submit that suggestion, and there's a form on X12's website, x12.org, that you can submit this suggestion for an update. It goes through X12's process, which is relatively rigorous, I'll show in a second, but one of the important, I think, steps in this is number 4, the consensus developed solution. And I'll show the next slide will illustrate that a little bit better. So I'm not going to walk through this, but included in these activities that were illustrated here are deliberations on the business need that's submitted, starting with this suggestion, the implications as well as the technical aspects to it. They're conducted within the subcommittee, which is the developing subcommittee box at the bottom. And then again by X12's technical assessment subcommittee, which is X12J. Anything that comes through X12 out of a subcommittee, once they have blessed it and said, we'd like to move this on through their process, and they've sent it out to the technical assessment subcommittee for their review. They look at to make sure it is a sound solution that will be well represented in the resulting X12 work product. This process is rigorous for a reason, is that things are vetted. Stakeholders have several opportunities to provide feedback and to participate, not just in one of the developing subcommittees, but also the technical assessment subcommittee, as well as other aspects of it throughout this rigorous process. Okay, that's a little bit background on who X12 is and how the work that gets done, and in this case has been done, to produce the 8060 transaction sets and implementation guides. So now I'll give a little bit more about where we are with it and what's happening. In September, we published of 2025, we published the 8060 version of the current. The 5010 version is the current HIPAA mandated implementation guides, and the 8060 version we produced in September of last year. In December, X12 submitted its recommendation for advancing those versions to the 8060 set, as well as, of course, notifying all of the other members of the designated standards maintenance organizations and the related entities. So we've got a landing page here on x12.org, and I would suggest that after everyone sees this, this is an active link, and you should be able to bookmark it. It is just links to related information about that. So that about the recommendation, the formal recommendation letter is available online. There's the member announcement, the change reference documents, which I'll go through in a little bit more detail in a minute here. And then also when we have a webinar, we're doing a webinar series that I'll also talk about to introduce each of these new versions and talk about what the benefits and specific changes are at a relatively high level, but with some more detail so people can get a better idea of what to expect as far as what are the opportunities they can seize, as well as what the implementation challenges may be. So from the HIPAA recommendations page, which is on the upper left-hand side, you'll see on the right-hand side of that page is the purple box that related links. And the change reference documents, which I've got also on the right-hand side there, encircled somewhat in red, are some of the other related documents we're making available for each of the recommended guides. To access the change reference documents page, you will need to create a free X12 ID. And when you look at the link, it'll ask you to sign one, or you can sign in with your X12 ID or create a new ID. But this information is free other than access to the actual implementation guides. If you're interested on X12's Info Center, which is on x12.org, there's additional information about X12 ID, what it means, how it's used, and so forth. And that's under the informational overview section. So this is the change reference documents page, and there's some obviously pros information content that we'll be updating to better describe all of the artifacts we're making available. But currently, obviously the recommendation letter is available. There's links on this to the 8060 guides in glass, as well as the 5010 counterparts. For some of the guides, there's also, and we're more being released weekly, a link to a PDF of the benefits summary. And this is also a prose document that describes in plain English what the expected benefits and specific to what we think are high value changes to each of these guides between 5010 and 8060 are. Followed by that is the transaction set listing markup. And this is, I think if you're an implementer that are trying to understand what has changed, it would serve as a good little roadmap. It won't tell you every little change that happened, but it is a good roadmap of where do I need to look within the transaction set listing to see the changes. And then you could reference the actual guides in glass, or also in the next column is a mechanical comparison report. And this is a machine generated comparison between the 5010 version and the 8060 counterpart for what has changed. These documents can be pretty lengthy. Hopefully it will be really helpful to ensure as an implementer that you have covered everything that needs to be covered. And then finally, on the right-hand column, we have a link to the education presentation. As they're delivered, we've delivered 3 so far. So one thing I wanted to mention that it's critical for each organization to review the changes between 5010 and 8060 independently. We're glad we can provide these tools as reference for what you should look at and consider, but you really need to review the details yourselves, especially to consider when you have a proprietary system, and process supporting those systems or systems supporting the processes, you can understand what the potential impact may be. And then ideally, you can hopefully realize the intended benefits that we've documented in the benefit summaries. So I'm going to just go through, I've got a couple of slides here to talk about some examples of the benefits. Obviously, today, we don't have the time, and I'm not sure it's necessarily the right audience to talk about all of the changes and expected benefits, but I've just put a few different categories and examples here that a lot of these changes, and these aren't specific to one of the guides, but these are across several of the guides. Streamlining providers' revenue cycle. A great example of it is one of the changes that replaces the CAS segment in the 835, and this is applicable not just to remittance advice, but also to the claims with the RAS segment. And that is important because health plans can now report back to adjustments on billed or claimed services on a line item and include many adjustment reason codes and remittance advice remark codes on a single claim instead of being limited as they were in the 5010 version. For a provider, obviously, the benefit is you should have more transparency and accurate information to why things have been adjusted. Expanded diagnosis reporting, the coordination of benefits enhancements, which obviously is a big deal, we believe, when it comes to primary, secondary, tertiary payer scenarios, which we know are pretty popular within the industry. And then expanded use of external code sets. And this is also an important consideration. If you think back to what I said earlier, we have the Accredited Standards Committee and then the Registered Standards Committee. Moving code sets from internal, which means they're internal to the X12 standard, and therefore they can be updated essentially once a year with our annual release cycle, to external code sets means external code sets are generally updated up to 3 times a year. So as the need arises, we can expand and update those code sets a lot faster for the benefit of the industry by moving them into external code sets. Improving accuracy for adjudication, reporting, and reconciliation is a very high-level benefit. And I've listed 4 on this slide. There's dozens within the 8060 version relative to the 5010 version of these guides that ideally are going to make it easier for health plans to adjudicate more accurately, report back either through remittance advice or otherwise to the providers, as well as a reconciliation for the providers, clearinghouses, and others based on a more granular detail of information that's provided, as well as supporting property and casualty coverage and reporting, which is an important consideration in the industry. Then supporting additional lines of business, and this is largely requests came in from our, I would say, industry partners, but including the dental industry, as well as pharmacy for electronic prescribing. We've got additional guidance in some front matter, as well as facilitating a lot more detail related to claims, payments, eligibility, related to supporting those lines of business. I've already talked about the more granular use of codes for inquiries, requests, adjustments, extended support for dates going back, and this is one that came up when we looked at the 270, 271 eligibility. Going as far back as timely filing for claims, and that is a big improvement, I believe, that will benefit providers in particular with the 8060 version. And then, of course, the support for digital member ID cards. Okay, I referenced earlier the education and information series. We've already had 3 of these, and they're publicly available. The March 31st, we had an extended session to talk about the healthcare eligibility benefit and inquiry. Then on April 9th, about the healthcare payment remittance advice implementation guide. And then just yesterday, about the 3 healthcare claims, the professional, institutional, and dental implementation guides. At the end of every one of these sessions, we've provided a survey that we've got relatively good responses on as far as the volume of responses. And I would say overwhelmingly positive feedback and appreciated the level of detail by our experts. These presentations, they weren't built with artificial intelligence. These were real people, the volunteers who participated in the development of these new versions. In some cases, the leaders within that work group or related work groups within the X12 subcommittees are presenting this information. So these are the industry experts, probably know more than anyone else on the planet about these guys, have been leading these education series for us. We've got some others in the queue that we'll be announcing in the coming weeks, so stay tuned on that. Just a little bit, you must register for each session. The good thing is once you attend one of these sessions, you will be included on the distribution for every session as they are released. We are recording them. We're not planning on making the recordings available right away because we're going to do this again. This won't be, we're going to do the 837s once and the 835 once and the 27. We've recorded them. We're going to review them, look at where we can improve, add content based on feedback, and then offer them again. So we also, again, and as I said, on that recommendations page, the change reference documents page, we have a link to a PDF for each set of presentation slides. We'll be adding the 837's presentation later this week as we just concluded it yesterday. Okay. As a wrap up, I just wanted to mention X12's next standing meeting. We meet 3 times in person generally per year, and it's typically winter, summer, and fall. We're meeting on June 7th in Philadelphia at the Sonesta Philadelphia Rittenhouse Square, a great facility if you've never been there. Registration is free for X12 members. If you're not an X12 member and you are interested to come to experience, to see what's happening, as I say, to see how the sausage making, what really happens, you can register online. And if you're not a member, complete the non-member registration form, and we'll get back to you about how to attend. Then finally, learn more about X12. To all of these announcements that I've referenced, we've sent out about the education webinars, about the benefit summaries and so forth. We post on x12.org under news. And that's where you'll also see under x12.org news, the link to the recommendations page. Also through X and LinkedIn, which are the 2 social media platforms that X12 uses, we're pretty consistently posting updates on what's happening, what we're releasing, and what's scheduled to be released. Okay, I think that is it. But finally, if you have any feedback on this or otherwise related to what X12 is doing or potentially not doing, please let us know, x12.org/feedback. Thank you.
Thank you, Andrew. We appreciate that overview of X12 and your processes, and of course your education as well. And thank you to Joe and Arna for answering the questions in the chat. Again, as a reminder, it's your opportunity to ask questions and make comments. We will be capturing all of that. And with that, I'm excited to introduce Nancy Spector, who is WEDI's Senior Director of Federal Affairs, and she will be moderating our first stakeholder panel, which is the Designated Standards Maintenance Organizations. Nancy, I'll turn it over to you.
Thank you, Rob. And I want to just jump right into our first panel. We have the Designated Standards Maintenance Organizations. We have Arna Meyer, who's committee member for the Dental Content Committee, Daniel Freeman, Chief Standards Development Officer and Chief Artificial Intelligence Officer at HL7, Margaret Weicker, Vice President of Standards Development for NCPDP, Terry Cunningham, Chair of the National Uniform Billing Committee, and Julie Brown-Georgie, Chair of the National Uniform Claim Committee. So I'm going to start just jumping right in, and I'll turn over to Arna to do her statement.
Thanks, Nancy. I'm assuming you can hear me just fine. So yeah,
Yes.
I am beautiful. Thanks for the opportunity here. I'm the designated member from the Dental Educational Content Committee, representing the dental industry. And I'm just going to read our statement. Our members were surveyed on the 8060 readiness of the dental industry. And the dental industry understands the modernization goals of X12 8060 and recognizes its potential to significantly improve interoperability, data quality, and alignment with modern administrative workflows. Our stakeholders see real long-term value in enhanced clinical data structures, improved harmonization with operating rules, and the convergence of administrative standards with our ADA dental claim form. I can't emphasize that enough. Our paper form actually can transmit more information than our EDI can at the moment. However, this support is conditional. The industry's position is clear. The success of 8060 for dental depends not just on the technical capability, but also enforceable usability, sufficient time, and meaningful implementation guidance. From the dental industry's perspective, the move from 5010 to 8060 represents a fundamental structural change, not an incremental version update. The key realities for us include an introduction of new segments and expanded data elements, significant re-engineering of claims, eligibility, payment, attachment, and status workflows, rewriting of edit libraries and validation logic, and the concurrent support for multiple X12 versions during this migration. For dental payers and vendors, this translates to a multi-year development cycle and material financial investment. For our providers, particularly the long tail of small and solo practices, the risk of revenue disruption during transition is substantial if timelines are compressed or guidance is insufficient. A central concern raised across the industry is that structural capacity alone does not guarantee interoperability. The dental industry has prior experience with optional fields in 5010 transactions, particularly in eligibility and benefit responses, that technically exist but are frequently left unpopulated by payers or omitted from vendor implementations entirely when they were perceived as unused by dental. There is strong concern that without clear requirements, 8060 could repeat this pattern at a greater scale. The first is the diagnosis to service line linkage. So when diagnosis codes are reported, the ability to link them meaningfully to dental service lines must be required, not situational. This linkage is essential to preserve alignment with the ADA dental claim form and enable consistent adjudication and analytics. The second is our minimum data content expectations. Where the 8060 schema enables tooth level, surface level, or benefit detail, operating rules or implementation requirements must define minimum response content when such data exists in payer systems. And the third is avoiding and what we call empty on interoperability. Without enforceable requirements, dental stakeholders fear an environment where new segments exist in theory, but are left blank in practice, which is undermining the promise of this standard. There's also strong consensus across the dental industry that an extended adoption timeline is essential. Stakeholders consistently indicate that whilst 18 months may be feasible for early adopters and niche vendors, 24 to 36 months is a necessary timeline for broad, safe, and equitable industry adoption. Longer timelines are critical for vendors serving small practices and for large payers coordinating across multiple lines of business. The industry urges NSG to recognize that a compressed timeline will increase the likelihood of production instability, inconsistent implementation, and revenue disruption, especially in dental, where margins and technical resources are often thinner than they are in the medical industry. The dental industry cannot succeed in this transition without clear, accessible, and dental-specific guidance. Our industry stakeholders strongly request that we have consolidated plain language change summaries, far more robust dental examples across all affected transactions, clear guidance on phased or stage migration approaches, industry-wide testing opportunities that include payers, vendors, and clearinghouses, and clarification that change documentation can be broadly shared, not limited by membership status. Readiness depends as much on information access and education as it does on technical specification. Finally, the dental industry asks NSG to consider provider impact as a first order concern. Dental providers, particularly small practices, have limited cash reserves to absorb claim processing delays, eligibility or benefit mismatches, or payment disruptions during cutover periods. Without adequate timelines, testing, and data completeness requirements, the operational risk of transition will fall disproportionately on providers that will least be able to absorb it. So, in closing, the dental industry's position is not one of resistance, but of measured, experience-based caution. We do believe that this X12 version 8060 can significantly improve dental interoperability, enable richer clinical administrative data exchange, reduce long-term administrative burden, but only if adoption is supported by sufficient time, mandated dental usability requirements, and robust accessible guidance and testing infrastructure. Thank you.
Thank you, Arna. We will now move to Dan Freeman.
Hello. On behalf of HL7 International and its over 1,600 members, thank you very much for the opportunity to share our perspective on the potential costs and benefits associated with the proposed adoption of X12's version 8060 transactions under HIPAA. I'm Daniel Freeman. I serve as HL7's Chief Standards Development Officer and Chief AI Officer. HL7 is an ANSI-accredited standards development organization dedicated to empowering interoperability of healthcare data globally. Our members include healthcare delivery organizations, government agencies, payers, pharma companies, technology vendors, and others who are directly involved in the electronic exchange of healthcare data, and many of which would be affected by a transition from 5010 to 8060. Our comments today reflect HL7's experience bringing together these diverse stakeholders together to create innovative interoperability standards that improve health. HL7 as an organization is deeply committed to international and domestic standards collaboration. As one of the US designated standards maintenance organizations, we work collaboratively with X12, whose standards are being discussed here. We appreciate X12's foundational efforts that have advanced the aims of the administrative simplification provisions of HIPAA. Compared to the currently adopted versions, the 8060 versions of the standards represent thousands of incremental updates based on change requests from industry stakeholders. In general, HL7 supports the adoption of modern standards that best meet the current interoperability needs of the industry. Prior industry hearings and NCVHS recommendations, such as the February 2019 Predictability Roadmap and the July 2022 recommendations to modernize adoption of HIPAA transaction standards, have emphasized the challenges that are inherent in our current approaches to named transaction standards and versions. In its recent CMS 0053F final rule, CMS adopted standards for healthcare claims attachments, including version 6020 of the X12N 275 and 277, along with HL7's consolidated CDA and digital signature implementation guide. Additionally, we note that CMS 0062P, if finalized, would adopt HL7 FHIR-based implementation guides as the standards for 3 prior authorization transaction types: referral certification and authorization, eligibility for a health plan transactions associated with prior auth, and prior authorization attachments. So there were 3 options for implementing the version 8060 standards framed in the recent WEDI survey. First, implementing all 8060 transactions as a group. Second, implementing 8060 by individual standard, kind of transaction by transaction. Third, implementing certain standards by group and others individually. In considering these options, we encourage NSG and others to consider and account for the current regulatory landscape and implementer readiness, both of which have evolved considerably since prior version transitions. We also want to highlight the importance of implementer feedback, such as you're hearing today, including the results from testing and pilot learnings as really being essential for driving virtuous cycles of standards development. And a measured, reasonable implementation timeframe is absolutely needed for diverse stakeholder success. And for its part, HL7 is committed to supporting the effective use of FHIR wherever it coexists with X12 standards. The marketplace is diverse in both its capabilities and resources. And so HL7 highlights three cost considerations relevant to version 8060 adoption. First, dual version support or multi-version support during any industry transition has advantages, but also carries significant cost. Second, the distribution of upgrade costs among key stakeholders should be both well understood and accommodated so that no stakeholder is at a notable disadvantage. And third, transitions to newer standards, especially significant upgrades, are really aided by broadly sharing technical learnings from trusted resources, such as the SDO and key federal and non-federal partners. In conclusion, HL7 supports thoughtful advancement to modern standards for HIPAA transactions while recognizing today's complex environment of attachment standards, interoperability mandates, and this potential version 8060 transition. Success will require balancing implementation, readiness, and innovation, incorporating stakeholder feedback, and equitably managing costs across the ecosystem. Through our relationships with the DISMOs, government leaders, and industry stakeholders, HL7 stands ready to help chart a pragmatic path forward. Thank you.
Thank you, Dan. I'll turn next to Margaret Waker for NCPDP.
Thanks, Nancy. I'm Margaret Weicker, Vice President of Standards Development at NCPDP, which is a non-for-profit American National Standards Institute, ANSI, accredited standards developer consisting of more than 1,300 members representing entities including but not limited to claims processors, data management, analysis vendors, federal and state government agencies, insurers, intermediaries, pharmaceutical manufacturers, pharmacies, pharmacy benefit managers, professional service organizations, software and system vendors, and other parties interested in electronic standardization within the pharmacy services sector of the healthcare industry. NCPDP provides a forum wherein our diverse membership develops business solutions, including ANSI-accredited standards and guidance for promoting information exchanges related to medications, supplies, and services within the healthcare system. NCPDP convened the Workgroup 45, 834, 835 FAQ Task Group, the Workgroup 45 DISMO Change Request Task Group, and the Workgroup 1 P&C and Workers' Compensation Monitored Billing and Education Task Group to evaluate the X12 version 8060, 270, 271, the 837P or professional, the 834, and the 835 transactions. These are the transactions that are mostly used in the pharmacy sector. The task group members use the X12 generated mechanical comparison reports to do their evaluation and analysis. I'm happy to report there were no showstoppers, negative impacts, or obstacles discovered. NCPDP acknowledges and thanks the members of the X12 work groups for incorporating our modifications and business requirements into these implementation guides. Regarding an implementation timeline, the task group members require at least 2 years from the effective date of the final rule to be in production, and request the implementation timeframe not overlap other major federal final rules. The task group members did not have the time or the bandwidth to complete a cost-benefit analysis. Thank you for the opportunity to provide these comments.
Thank you, Margaret, and we'll go next to Terry.
Thank you, Nancy, and thank you so much to everyone for having me. It's my pleasure to provide the perspective of the National Uniform Billing Committee as part of this panel. The National Uniform Billing Committee was convened and formed by the American Hospital Association in 1975, and the main purpose was to bring together all the stakeholders that would be involved in an institutional claim, would have an interest in the institutional claim, and develop a standard and single billing form and standard data set to be used by providers and plans, and it's for institutional claims. Subsequently was recognized under the HIPAA regulations as the data content authority for institutional claims, and also as a member of the designated standards maintenance organizations, as you might suspect, because I'm on this panel. As such, our review of developing standards is often largely focused in terms of the claim and the related standards to the claim. This is our area of expertise in terms of the committee members and the area of focus as we convene our groups. So as we approach this panel, I will note that we had the opportunity last week during a recent meeting to receive a little bit of additional insight in terms of the specific changes that are being made and updated as it relates to the claim. Specifically, Jamie, who's our X12 representative, provided insight largely in line with what you would have seen if you were on the X12 presentation yesterday, effectively presenting things such as the switch from CAS to RAS segments, the supporting of backwards dating of claims, the tooth reporting information, and the ability to support pay-to factoring agents. These issues did not necessarily generate a significant amount of discussion, and they haven't necessarily been issues that we've had raised to us as major areas of concern. That being said, it's certainly not a way that's not me saying that these are not issues that are important. It's just a way of me saying that I don't think the committee has had an opportunity to really gauge the specific need or impact for this. And really one of the large kind of questions we have as we approach this, and we've had as we approach any, is similar to something Daniel mentioned, is now the time to move to a new version of the standards? Is the juice worth the squeeze, to use a potentially overused metaphor? For example, as Andrew mentioned earlier, these standards work. What we agree with that. What we want to know is kind of to what degree do these standards work better than what we already have working, and to what degree is the investment of resources? How do we ensure that the investment of resources and the time both is it's worth it, as well as how do we roll a new standard out in a way that we're not overwhelming the industry? We haven't done a cost-benefit analysis similar to what Margaret had said previously, but we encourage CMS to just carefully consider these issues. I do intend to review. I have been participating in the calls, and I know that there's a kind of a benefit summary that Andrew mentioned earlier. It'll be my intention to make sure we review this with our committee in a more focused opportunity so that we can have this kind of informed perspective as terms of, well, this is such a benefit that we need to move, this is important for the industry. It's just, I know there was a request for a cost benefit analysis, and I don't think we've necessarily had the ability or the sufficient time to conduct that, but certainly something we look forward to doing moving forward. Last thing I'll note is, just because we're on the DISMO committee, I'll note it's been a pleasure recently to work with CMS on trying to update and modernize the existing DISMO process. I look forward to that continuing to be the process. I look forward to that continuing to occur. After a few years back when the 80/20 version was presented, it became clear that the existing DISMO processes had functions and needs to be kind of updated based on the industry practices. The NUBC looks forward to continuing that, particularly to developing an approach that can enable us to provide our kind of heightened expert commentary on emerging standards, to being able to provide kind of the strength in numbers, collective voice that this group potentially can have, and the ability to make sure that there's kind of industry perspective, which again, I appreciate WEDI for convening this because I think this is an opportunity to get some of that perspective as well. With that, that's what I've got for the committee. We really look forward to seeing some of the more specifics and having the opportunity to analyze some of the additional changes and trying to figure out that cost benefit analysis, and look forward to seeing exactly how CMS intends to roll this out in terms of timing and, again, that kind of balance to make sure that this fits within the larger industry implementation concerns. So with that, I will turn it over to, I believe Julie is next, but I'll turn it back over to Nancy to make sure I don't screw things up. So thanks so much.
Thank you, Terry. And yes, I will turn it over to Julie as our final panelist.
Hey there, good afternoon. It is very enticing to lead by saying the NUCC is aligned with the NUBC and echoes their comments, but I will extrapolate on that a bit. Thank you, WEDI, CMS, X12, and the industry participants for convening us for this discussion, and kudos to WEDI for holding their first federal policy consultation. I'm Julie Brown-Georgi, chair of the NUCC, and I'm going to be speaking from the perspective of the National Uniform Claims Committee. So NUCC's upbringing and charge is extremely similar to the NUBC. Our core interest is not simply whether the industry can translate one EDI version to another. Our concern is whether the professional claim data set remains nationally uniform, clear, usable for physicians, suppliers, payers, clearinghouses, and all the systems that connect them. So the version 5010 has served the industry for many years. There are pain points in processing as technology is imperfect. And so when a standard can have trouble with that, there may not necessarily be issues in the standard, but then there are also areas that were identified for improvement. But I say all of that to say, if there is a recurring issue that's not just a technology glitch, but an issue with the standard, that's when we start to see companion guide workarounds, portals, attachments, manual notes, phone calls, claim splitting, and all of these subsequent burdensome activities. And so from the NUCC's perspective, that's the central area to address within our purview. Non-uniformity re-enters the process through the back door, and our goal is to secure uniformity. So 8060 does offer a blaringly obvious opportunity to move forward. To echo Terry's comments, is that juice worth the squeeze? Yes, we can move some of the manual work back into the standard transaction. There's potential on the claims form for value and stronger data in areas such as like longer claim identifiers, device identifiers being an option to report on the claim, service date and time for electronic visit verification, capturing patient weight better. But this all comes back to, is implementation coordinated? Is it tested before moving forward? Additionally, we are in an interesting spot with the 1500 paper claim form. And NUCC believes the paper and electronic environments must be handled carefully. The 1500 claim form remains important, but we've transitioned to electronic professional claims for a reason, and they can and should carry data that will not fit neatly onto our singular one-page paper form. What we as the NUCC would need to do upon adoption, or ideally in advance of adoption, to make this as seamless as possible, is revisit our 1500 paper form, especially if every electronic enhancement was forced into that new paper form, which would upend quite a bit of industry to move from one page to two. But in lieu of that, we would then also be able to explore the instructions and the 1500 to 837p mapping to distinguish data that belongs and remains on the paper form, data that belongs in the electronic 837p only, and then data that can be captured upstream in EHR, practice management systems, authorization, prior auths, remittance, pharmacy-related systems, etc. So my takeaway for you on that is there is opportunity, but when it comes to our bread and butter, which is the data on the claim form, we have a space constriction, and there's subsequent guides that we can update, but then we're back to potentially a workaround that I mentioned before. On transition planning, we echo what others have said, our DCC comrades and DISMO comrades. The NUCC is really adamant about a defined dual use period for testing and migration, not indefinite support for two adopted standards. And we believe this for standards outside of 8060. We believe that it's extremely difficult for permanent dual standards to exist seamlessly, and it can increase the variation that the NUCC is inherently designed to reduce. So whether it takes the form of pilots, transparent readiness criteria, strong end-to-end testing, or a compliance timeline that recognizes small practices, vendors, clearinghouses, Medicaid agencies, Medicare, commercial plans, et cetera, we would strongly suggest having a set dual use period so that way we are not in perpetuity supporting two standards. Finally, I'd close with there's economies of scale if the industry treats 8060 as a shared platform modernization. So like common translator upgrades, common validation rules, common code list governance, shared testing scenarios, national training. The NUCC could contribute by maintaining uniform professional claim instructions, updating our 1500 to 837 map, and helping industry separate true national data needs from any sort of specific local preferences. But we, in summary, we see this as an opportunity to modernize the professional claim data set. We support moving forward. However, it is supported provided that the transition is coordinated, time limited, workflow tested, focused on reducing the manual work and really providing a realizable return on investment instead of just a new layer of variation. So thanks for the time to comment.
Thank you, Julie. And I want to thank all of our panelists for presenting your statements. We are over on our time, and I wasn't seeing any kind of questions or comments in the chat that I felt needed any of the panelists to clarify verbally. If there is something, though, that you wish to respond to, please do so. So with that, in keeping with the time, I'm going to turn straight over to Denny to introduce our next panel. Denny, if you're talking, we're not hearing you.
I am now. I would have needed to be made a co-host, and that has just happened miraculously. So thank you, Nancy. Thank you all for joining us today. My name is Denny Brennan. I'm the chair-elect for WEDI and the executive director for the Massachusetts Health Data Consortium. I'm joined today by an illustrious panel of payer and provider representatives. And we have 25 minutes or so to discuss with these leaders 8060 and to compare practical perspectives on the benefits and implementation considerations associated with its implementation. So first, allow me to introduce our panelists. We have Andrea Preisler. Andrea, am I pronouncing your last name correctly?
Preisler.
Preisler. E before I thought I might be wrong. That's why I'm asking. Andrea Preisler from the American Hospital Association. We also have joining us today, I believe, Christopher Graycon from Independent Health. Christopher, are you with us?
Yes, I am. Thank you.
Terrific. Thank you. And Dina Gerousis from the American Medical Association. Dina, are you with us?
I am. And good pronunciation. Thank you.
Thank you. I'm working on it. It's a life's work. Gail Coker, are you available to join us today?
Yes, I'm here. Thanks, Denny.
Thanks, Gail. Okay, great. So with that, I would like to turn it over to each of the panelists to provide your summary position on our discussion today of 8060. And Andrea, I'll start with you first.
Great. Thank you, Denny. Thank you also to WEDI and to CMS for convening us today. So over the past several years, the American Hospital Association has engaged actively and constructively in discussions regarding updates to HIPAA administrative transactions, including proposals to transition multiple transactions to X12 version 8060. We want to say that we appreciate X12's continued engagement with stakeholders like the AHA and their efforts to modernize the standards environments. At the outset, I want to be clear that hospitals support modernization when it is purposeful, well-sequenced, and meaningfully advances administrative simplification. Our position is not opposition to transition, but rather our assessment of the proposed X12 8060 transactions remains incomplete, as hospitals still feel like we need clear provider-ready information to understand the real-world impacts of a transition of this magnitude. So for hospitals, a critical input to that assessment is widely available plain language information explaining how 8060 enhances the currently mandated 5010 transactions. We appreciate the change reference documents and recognize their technical value. However, hospitals need a clear provider-facing summary that explains what has changed, why it matters, and how daily workflows and administrative processes would improve in practice if we make this update. Without that level of clarity, it's difficult for providers to evaluate the costs, operational impacts, and workflow changes, and of course, return on investment, particularly given that the transition of this magnitude spans multiple transactions and, of course, every vendor and trading partner that each hospital works with as well. I will say that we have appreciated the X12 8060 education series, which has been really helpful in raising awareness and walking through some of those proposed changes. Efforts like that are very valuable to hospitals, especially if they're paired with accessible written resources that hospitals could share internally and use to support some of those operational and business level decision making as they get into that impact analysis. So these considerations apply across the full suite of 8060 transactions, but they are especially important because a version upgrade across revenue cycle transactions will inevitably be disruptive and costly. A mandate to upgrade without a clearly demonstrated need for new functionality risk creating a significant investment without visible return. And in that context, transparency around provider relevant benefits is really essential. So this concern is especially amplified for rural hospitals and other providers under financial strain, including those experiencing the impacts of Medicaid cuts and coverage disruptions that are coming down the pike. So as most of you know, many hospitals already operate on very thin margins, and such large-scale technology and process upgrades can introduce additional financial strain to these very finite resources. So for these providers in particular, it's really imperative that the need for updated functionality and the value it delivers be very clear and compelling. At the same time, there are areas where hospitals do see some meaningful potential. For example, we find the updates to the eligibility transaction to be quite promising and worthy of investment. Providers are encouraged by enhancements such as the smarter member matching, the improved traceability, and clear prior auth indicators. I will also highlight here that the ability to perform eligibility checks based on service type or stage of care is a really significant advancement that could materially improve front-end workflows for providers and increase timely patient access. So we are really pleased to see those enhancements in that transaction in particular. However, overall, we still would like to see more granular provider-facing explanations of how these enhancements made on multiple transactions that providers use will really work together in practice, and if and how they address current roadblocks and headaches in the system. So providers are therefore asking, what specific problems does X12 8060 solve, and how will those solutions materially improve administrative processes for providers? X12 has undertaken very meaningful work to advance these transactions, and we do welcome continued engagement that helps translate all of the work that X12 has done into clear workflow outcomes and benefits. Looking ahead, we think a reasonable path forward is to continue parent engagement efforts like that education series and change reference documents with, again, some plain language summaries of enhancements that really clearly articulate the value proposition of 8060, particularly in comparison to what we all know today being 5010. So this will better position hospitals to complete their assessments and responsibly plan for a potential transition. So ultimately, the AHA remains committed to modernization that delivers administrative simplification. Hospitals are open to a transition here and interested in improvement. At the same time, given the cost and disruption associated with upgrading the full revenue cycle of transactions, again, especially for those hospitals under financial strain, it's essential that the need for updates and the ROI of the improved functionality be very clear and visible. So to that end, we again welcome information from X12, as I mentioned before, and we urge reasonable timelines to CMS. We urge reasonable timelines in any proposed transition, ideally 24 months from publication of any final rule. And with that, I will turn it back over to you, Denny. And once again, thank you, WEDI, and thank you to CMS for having us today.
Thank you, Andrea. That was very, very helpful and insightful. I'm going to turn now to Gail Coker from the Blue Cross Blue Shield Association. Gail?
Thank you, Denny. Thank you all. Blue Cross Blue Shield Association is very happy to be here. We appreciate what WEDI is doing and holding this session, and we appreciate the partnership with the National Standards Group as we have these important discussions. The Blue Cross Blue Shield Association and many of the Blue plans participate in the development of these standards, and so we know that there are important things and things that have been added that we know will be valuable, but we have not been able to conduct a detailed gap analysis or cost benefit analysis with the plans or our own implementations to determine exactly what the impact will be. We believe that this, however, will be a very large implementation, and we're very concerned about any kind of timing and how that would interact with other federal requirements that are placed on the plans, as well as our industry partners, our providers and clearinghouses, because such large implementations take significant resources and often impact not just one system, but multiple systems and many systems which are complex. So we think it's very important that any forward movement is done thoughtfully with taking all the consideration in terms of timeline. Fully agree with those that have called for 24 months. We think that's important. We need to remember and learn from what has happened in the past and try not to repeat those. We moved forward from 4010 to 5010, and then we had to kind of pause and extend the time frame. We think that any change to move to 8060 is going to be just as significant as it was from 4010 to 5010. And so therefore, we really would request that there is thoughtful evaluation of, is this the right time? When is the right time? What is the right amount of time? Sorry. And actually, that was very short and sweet today, Denny. That really
all
was
right,
all.
Gail.
Yeah, I mean, we just have not had the opportunity to do the detailed gap analysis and ROI that we would do with our Blue plans to provide any more detailed comments. Again, we appreciate the work that X12 has done. Many of our plans are heavily involved, and we appreciate the ability to participate. But we think this is the start of conversations and the start of evaluation. I don't think we're at the end of that piece of the process.
Nor do I, Gail. Thank you very much for your commentary. And I'll now turn to Christopher Grayken, Solution Architect from Independent Health.
Thank you, Denny. I'm representing a payer out of Western New York. As a payer and this organization is active members of X12, I'm so glad to see that we are finally moving ahead. Also so appreciative for X12 for starting the education series on 8060 by transaction set. I'm just recommend, like others had mentioned, that people should be on the lookout for the future sessions and review the materials that have been previously published. Now, looking at the questions that had been asked by WEDI in regards to impact, we know that there will be costs. The costs that we see, we don't know what the costs will be because we have not had info from our software vendors who have what their changes will be to accommodate 8060, and most likely they haven't done any analysis either. We have not done our own analysis. We can figure out what the processes we might need to change, or somehow what we may need to map to or from 8060 transactions. By not knowing the changes to our software interfaces, we don't know what we will be needing to map to or from with them. It's also unknown now with the event of CMS 0062P, what that effect will be on the 8060 NPRM, or absent an 8060 NPRM, what that means to the current processes under 5010. Currently, my organization is focused on running the business and interoperability. Interoperability has taken about 25% of our IT department working on it, not to mention those on the business side. Regarding 8060, I see that it will take fewer resources, IT and business, than we're currently on interoperability, as interoperability was greenfield work, required a ton of learning about the data structures, the technology, and modifications on the business end too. For 8060, I see this as more as an incremental change to handle differences, determining the business opportunities that the changes present, and mainly testing internally and externally. I foresee that we could do this within our existing staffing and taking fewer people than we needed to go from 4010 to 5010, particularly with newer tools to help us with some of the mapping and testing that we didn't have all those years ago. I also see that there are unknown opportunity costs, either additional costs we pay now or living with challenges that we have factored into daily work or cost of things we do not have. For example, what could payers or all payer claim databases be able to find out via analysis with having more diagnosis codes or having the DI of the UDI, being able to have claims adjudicate instead of being denied for having multiple of the same service on the same day. Much easier is for payers to administer FSA and HSA enrollments with the changes that now have been added to the 834. That it might help clear up timely filing issues with providers submitting the date of the claim was sent, which could be different from when the payer receives it. And similarly, payers reporting the clean claim date, if that's different than the receipt date. And payers being able to send greater specificity in the 271, as Andrea had mentioned, in regards to prior authorization referrals and first dollar coverage. In regards to the timing, I look at also back at the most recent attachments final rule and wondering whether attachments should be skipped at this time of moving to 8060 or potentially have that as a secondary timing for that, or maybe just leave it for the next upgrade in version. So that way attachments have time to develop in what we are going to need to build the next 2 years. As far as the rollout, I think it should be done as a complete suite for the current standard transactions. If it's spread out over too long, it really could impact a lot of the other implementations that are coming out due to regulatory or legal things in the future. I do wonder about the timing with the CMS 0062, whether it could collide, depending upon when that is published and its dates and the dates here in the 8060 NPRM or final rule, particularly with the proposed retirement of the 278 and taking away some of the functionality from the 270, 271. Also with the final rule on NDC code changes, I wonder whether NSG will have to factor in either an upgrade post 8060, because that's not handled in 8060, but will be hopefully in a near future with an X12 version, or whether when they come out with a final rule that they would name whatever the most recently published version is at that time, which case I believe the NDC changes will be accommodated in there. And finally, I don't see a lot of issues with the handling both 5010 and 8060s as coexistence. There will be some challenges, but I don't think it's going to be so great. I'm also looking forward, as Mike Cimino has talked about in the past, of moving ahead with more frequent updates to versions. Looking forward to maybe a regular cadence of every so many years of moving up in versions. So that way, as there are new regulatory or legal things or changes in industry, that those will be able to come up like the NDC code changes. So thank you very much.
Hello, everyone can see my screen.
Thank you, Dino. Sorry for my being momentarily unavailable, but thank you for joining us, and I'll turn it over to you from the American Medical Association.
You're good. Thank you. Hello, everyone. My name is Dino Garusis. I'm a Director of Informatics at the American Medical Association. I want to thank WEDI for the opportunity to serve a physician perspective as part of today's panel. VMA supports evolving administrative standards, and we recognize that modernization is necessary over time. At the same time, our responsibility is to represent the physicians and medical practices that ultimately must implement the standards in real-world clinical and business environments. At this time, VMA believes it will be premature to support adoption of X12 version 8060 under HIPAA without clear evidence of provider value, manageable implementation costs, readiness across the provider community. This position is consistent. Oh, sorry. I went. Okay. Apologies for that. I skipped a slide a little soon. This position is consistent with prior AMA testimony to the National Committee of Vital Health Statistics in late 2022 and early 2023. Then, as of now, our concern is not whether evolving the standards appropriate, but whether providers have sufficient information to fully access costs, benefits, operational impact for any regulatory adoption. From a provider perspective, a few challenges stand out. Okay, first is complexity and capacity. Version 8060 is large in scope and technically complex. Physicians and practice staff are often reliant on vendors to interpret and implement changes, and many practices face limited internal capacity to absorb additional system upgrades alongside ongoing operational demands. Second is testing and readiness. I think several other panelists have addressed as well too. We continue to hear concerns that updated standards are not being sufficiently tested in real-world provider environments. Testing that does not reflect day-to-day practice operations can underestimate disruption, especially at a time when providers are already implementing multiple health IT initiatives, including API-based interoperability and prior auth reform. For this cost and return on investment, providers face immediate implementation costs, including vendor upgrades, workflow changes, testing, and training. For many 80/60 transactions, however, the return on investment for providers remains unclear. Without stronger evidence, the adoption will reduce administrative burden or improve efficiency. It is difficult to justify moving forward under HIPAA. We also want to acknowledge positive aspects of version 8060. In particular, we appreciate the updates to 2070, 2071 eligibility transactions, including efforts to improve alignment between eligibility responses and prior auth requirements. That said, the practical benefits of these enhancements for providers is uncertain given the current policy direction towards FHIR-based prior authorization workflows. More broadly, physicians are concerned about the need to support multiple parallel administrative systems at a time when industry momentum continues to shift towards API-driven solutions. There are also specific ongoing concerns, including the inclusion of virtual credit card information on the 835, the 835 healthcare payment. This remains a significant issue for physicians and practice staff due to associate fees, reconciliation challenges, and increased administrative burden. The AMA continues to engage with provider caucus at X12, and the concerns raised in those discussions reflect what we hear more broadly from physicians nationwide. The message is consistent. Providers need clearer value propositions, realistic testing in provider settings, and greater confidence in adoption will simplify rather than complicate administrative workflows. In closing, VMA supports continued collaboration among WEDI, CMS, standards organizations, and industry stakeholders. We encourage further data collection, expanded real-world testing, careful consideration, whether phased or targeted approaches to adoption would better serve the healthcare system. Until providers can clearly understand the cost, the benefits, and operational impact of version 8060, VMA urges caution and evidence-based decision-making before moving forward with HIPAA adoption. Thank you.
Thank you, Dino, and thank you to our panelists for your thoughtful commentary. With that, Rob, I'm going to turn it back over to you. I believe we have a break coming up.
We do, Danny, and thank you for monitoring the panel, and a big thanks to Andrea, to Gail, to Chris, and to Dino. With that, we'll have a quick break. We'll come back at 1:55, so we have a few minutes to get a snack or a drink, and then we'll jump into our intermediary panel again at 1:55. Thanks so much. To move into our next panel, and that will be a panel of intermediaries, and we are very lucky to have 4 national experts to give their perspectives on version 8060. We'll start off with Jamie Mostedler from Japari Solutions, Nick Radoff from Steady, our own Pam Gose, who is representing the Cooperative Exchange, and Michelle Berry from Availity. So, Jamie, I will turn it over to you first.
Great. Thank you, Rob. Japari would like to acknowledge that the implementation of the X12 8060 transactions will require meaningful investment across the industry, including system upgrades, testing, trading partner coordination. However, we believe these costs are outweighed by the significant long-term benefits and the operational efficiencies that are introduced in the 8060 enhancements. Notably, the 8060 version includes critical improvements that the industry, particularly the property and casualty sector, has been anticipating, enabling better data exchange, improved clarity, and reduced reliance on manual processes and workarounds. These enhancements are expected to drive burden reduction, increase automation, and improve overall transaction accuracy and timeliness. To fully realize these benefits, we're recommending that there be a coordinated industry-wide rollout and adoption strategy, a common implementation framework, including aligned timelines and consistent requirements across payers, to minimize fragmentation, reduce duplicative effort, and support a more efficient and scalable transition for stakeholders. We're also recommending that for the implementation of the X12 version 60 transactions be deliberately sequenced to ensure successful industry adoption and minimize disruption. We feel it would be good for the industry to complete the implementation of the attachments and prior auth requirements before requiring the 8060 transactions to be mandated, allowing stakeholders to focus resource and avoid overlapping regulatory burden. Further recommending that the full suite of the 8060 transactions be implemented concurrently rather through a fragmented transaction-by-transaction rollout. A unified implementation approach will promote consistency across trading partners, reduce operational complexity, and accelerate industry-wide standardization. While early adopter programs may provide valuable implementation insights, we are recommending that the establishment of a single mandated compliance date for all payers to ensure alignment and prevent prolonged dual version processing environments. The client compliance date should be strategically selected to avoid high-risk operational periods, example being January 1 of the calendar year, thereby reducing implementation risk and supporting a more stable transition. Jupari is highly encouraged by the transition to version 8060 and the opportunity it represents for the industry to modernize administrative transactions. The move to 8060 reflects more than 50 years of thoughtful enhancements, industry collaborations, and lessons learned since prior versions, resulting in a more robust, flexible, and capable standard. These enhancements are expected to significantly improve data quality, expand support for evolving business needs, and reduce reliance on proprietary workarounds that have developed over time. For many stakeholders, particularly within the P&C sector, 8060 represents a long-awaited advancement that better aligns transaction capabilities with real-world operational requirements. Finally, we believe that this transition is not simply a version upgrade, but a critical step forward in advancing interoperability, reducing administrative burden, and enabling more efficient, accurate, and scalable healthcare data exchange. With appropriate coordination and implementation planning, the industry is well positioned to fully realize the benefits of the 8060 standard. All right, back to you, Rob.
Great. Thank you, Jamie. Next up will be Nick Radoff from STEDI.
Thank you. Can everybody see my slides there?
Yes.
Okay, great. So yes, my name is Nick Radov. I'm a technical product manager at STEDI, which is a programmable EDI clearinghouse processing millions of HIPAA standard X12 version 5010 transactions, primarily for digital health providers. I'm also STEDI's X12 representative and a co-chair of WEDI's Emerging Technology Work Group. But just to be clear, for today, I'm speaking on behalf of STEDI only, not on behalf of WEDI. So briefly, STEDI strongly supports upgrading to X12 version 8060 across the entire suite of HIPAA standard transactions, and perhaps even adding additional standard transactions such as 999 for general acknowledgements or 277CA for claim acknowledgements. Overall, our experience has shown that version 5010 transactions are working well in production, but version 8060 will deliver some key improvements for providers, payers, and patients. There's too many improvements in 8060 to cover in the 5 minutes I have, but I just wanted to highlight a few of the key limitations that we've found in version 5010 and how 8060 can solve for those. So probably the biggest area of improvement that we've seen, or the biggest area for improvement that we've seen is in the 271 eligibility response transactions. So version 5010 first came out in 2009. Health plan structures have evolved quite a bit since then. So some of the nuances like a provider's in-network or out-of-network status, or things like specific tooth data or shared frequency limitations for dental can't be represented in codified fields in the version 5010 271 response. So instead, providers have to parse out unstructured narrative text when they get it at all, and that's non-standard across health plans. So in cases where that text isn't available, then the provider just ends up having to call the payer, the call center, or log into a proprietary web portal. And it would really be a lot better for everybody if we had those in a standard format. Another issue is that with the version 5010 271, the benefits just come out as a flat list. So that can be confusing in cases where a single patient is covered by multiple health plans issued by a single payer. So again, they end up having to call or use a proprietary web portal. The shortcomings, though, in version 5010 aren't limited to just eligibility checks. Version 5010 claims they don't support prospective 837P professional or 837I institutional claims in order to be able to get good faith estimates. So you can do prospective claims for dental, but not professional or institutional. And this is becoming more and more important as copays and deductibles continue to rise, and would align with the policy focus now around transparency and coverage. So while it's not a panacea, version 8060 has some really key benefits in several areas that address those limitations in 5010. We now have structured fields where payers can state explicitly whether they consider a provider to be in or out of network, as well as getting more details about network tier status where they have multiple tiers. They can also group benefits together in cases where patients or members are on multiple plans simultaneously. Sometimes we see patients that are on both a medical and dental plan from the same payer, or both a commercial group plan plus a Medicare Advantage plan. So now those can be grouped together so it's crystal clear which one they apply to. And then on the dental side, we'll be able to send multiple discrete ADA CDT procedure codes, in a single benefit line. So that's useful for shared frequency limitations, like many dental plans would only pay for one set of x-rays per year, but there's multiple CDT codes that could apply. They can also send tooth-specific data. And then on the prospective claims front, the 837P, 837I transactions will allow providers to ask health plans exactly how much they would reimburse for a course of treatment and how much that remaining patient responsibility would be. So these prospective claims will let providers give patients who are covered by active health plans some real good faith estimates for their out-of-pocket costs for treatment, so the patients will be able to make an informed decision about their own care. So that's just the highlights. There's many more benefits, and taken together, all of these improvements will really reduce provider abrasion, lower administrative costs for payers, and help to prevent surprise bills for patients. At Steady, we're looking forward to supporting version 8060 as soon as CMS mandates it. We would also encourage CMS to adopt a more frequent X12 version upgrade or update cadence. The version 8060 is a significant update after nearly 15 years now without a major change. So we think that going forward, smaller but more frequent updates would be less disruptive for everybody in the industry. And we look forward to working with WEDI, CMS, X12, Cooperative Exchange, and all of our trading partners to make this upgrade a success. So thanks again to WEDI for allowing us to share our perspective today.
Great. Thank you so much, Nick. Next up will be Pam Grosset representing the Cooperative Exchange. Pam?
Thank you. And I'm going to try and share here. Sorry, one moment. I'm going to try again. Sorry about that. There we go.
You're up. Yep.
All right. And you know what? When I share on that screen, I cannot see what I want to say. So I'm going to stop sharing until the very end. So sorry about that.
Pam, you want me to show the slides on my side?
There's only one that I really want to share. So
okay.
I'll just pop that up at the end. Sorry about that. So welcome, everyone. I'm Pam Grosset. After all of that, I'm the past board chair and chair of the Education Committee for the Cooperative Exchange, which is the National Clearinghouse Association. Thank you for the opportunity to provide input into the updates to 8060 for the HIPAA transactions. The Cooperative Exchange is composed of 20 member organizations representing over 90% of the clearinghouse industry that supports over 1 million provider organizations through more than 7,000 payer connections and 1,000 health information technology vendors, and processes over 6 billion healthcare transactions annually. The Cooperative Exchange supports HHS's efforts to streamline healthcare and create a more efficient and effective healthcare ecosystem for the American people. In their recommendation letter to CMS and supporting documentation, X12 has outlined dozens of significant enhancements that were made to the existing HIPAA transactions based on evolving business needs voiced by healthcare industry stakeholders. The Cooperative Exchange agrees that these and other enhancements will satisfy new business requirements and resolve significant gaps in business processes and administrative functions, and will assist the industry with aligning with current and upcoming regulations. The Cooperative Exchange also supports the non-substantive updates, which decrease misinterpretation and ambiguity and promote precision in deployment across all stakeholders, thus reducing the overall operational cost to support the updated implementation guides. Cost for making these updates is difficult to quantify at this time. Many entities will not evaluate costs until a proposed rule is in place and the exact requirements are more clearly defined. Clearinghouses find it hard to compare the cost of this upgrade to the upgrade from version 4010 to 5010 due to the changes in system configurations and length of time that has elapsed since that last conversion. But all agree that the process of end-to-end testing will be significant and will encompass a major portion of the cost, as it would be with any change to any standard. We do have lessons learned from previous conversions and now have the benefit of AI that can assist with the development and internal testing, thus reducing the cost, but again, it's difficult to quantify at this time. The Cooperative Exchange recommends that WEDI review the end-to-end testing process that was previously defined to define the testing requirements today and milestones, and share those with CMS so that expectations and timing are clearly understood across all trading partners. When looking at the question of timing of the mandate and rollout of the multiple transactions, the Cooperative Exchange would like to emphasize that a compliance date of January 1st is very problematic, as Jamie mentioned earlier. Many activities are happening at the end of the year, so incorporating changes of this magnitude at that same time becomes very challenging. A compliance date in the second or third quarter would be more manageable. Some transactions must be implemented together due to their relationship with each other. The Cooperative Exchange is in favor of a single compliance date for all transactions and all entities. We do not see a benefit in having multiple rounds of implementations, and in fact, repeating the end-to-end testing process would be complex, costly, and burdensome. Including provider vendors, especially EMR/EHR vendors, in this requirement is especially important as well to ensure the ability of providers to meet the compliance dates. The Cooperative Exchange has long advocated for a change to the current regulatory review and rulemaking process and its known challenges, and supports a federally established known and predictable version update cycle under a federal guidance framework that allows two versions of a standard to coexist. Transitioning from the current federal effective date cycle that requires a cumbersome and time-consuming regulatory review and rulemaking process to a federally established known and predictable cycle of every 3 years would allow the industry to realize innovation and apply version updates in smaller, incremental changes versus huge steps and major changes due to long regulatory timeframes. In other words, evolutionary versus revolutionary, or making it a process versus an event. Using this predictable cycle, industry stakeholders would become acclimated to the framework process and requirements, providing a consistent means for stakeholders to participate and comment on proposed standards or operating rule updates. A known and predictable version update cycle would also allow affected stakeholders to plan, budget, and resource effectively and introduce changes in a flexible cadence as their business needs warrant, while also, by nature of the process, advance the industry forward to continuously improve and modernize applicable standards and supportive operating rules. The Cooperative Exchange has an illustration, which I'll show in a moment, of a hypothetical 3-year implementation cycle showing how standards can consistently and predictably move to more current versions while requiring the industry to support no more than 2 versions at one time. And I will bring that up now. So this is an illustration that the Cooperative Exchange developed several years ago, demonstrating how we could cycle in a 3-year implementation cycle period where we are bringing in a new version while we're rolling out the previous version and adopting or developing the next version, so that we're never supporting more than 2 versions at one time while the previous version is rolling off. We're moving into the current version and again developing the next version coming up. So it's very doable and it gives us then a very predictable cadence that the industry would understand how to support. So thank you very much for the opportunity to comment. And let me just make sure I didn't have anything else to say there.
Pam, if you would put up your last slide and maybe put your Word document down so folks can have a quick look at the chart.
Yes.
Excellent. Yeah. And again, for folks, these slides will be made available after the event as well. So thank you, Pam, for that. And we'll move to our last panelist, Michelle Berry with Availity. Michelle, welcome.
Thank you. Good afternoon, everyone. Just want to say thank you for allowing all of us to get together today. Thank you to WEDI, CMS, and our partners in the industry, spanning from every agency to clearinghouses, intermediaries, and our partners. One quick second while I prepare to share my screen. Hopefully you are seeing the full screen.
Yes.
Great. So again, just want to say thank you. We appreciate the time today to talk about the move or the next advantage of moving to the X12 standards. Couple of important tidbits of information when we talk about connecting the healthcare infrastructure. Think about, over 95% direct payer connectivity. And again, throwing this out to the team here so that you can understand the importance and the complexity behind really driving data and information. Over 3.4 million connected providers that we participate and engage with regarding transactions, transactional information, data exchange, and over 17,000 connected B2B partners, which allows us to look at 4.5 trillion in billed claims annually. So when you think about the collaboration, the network, and innovation, I want you to know that that is the level specifically of information that I obtained and wanted to share today specifically so that we had some concrete real-time statistics. A couple of other things that are super engaging and important to understand. From an availability perspective, implementing the next version, the 8060 version, or the next version would be very meaningful and impactful across our whole entire systems And I say systems because we look at infrastructures. We're looking at that connectivity and driving long-term benefits of moving to the next version. Data accuracy, making sure that there is less complexity and improve data quality with those modifications and changes to the 8060 version and next. Keeping in mind transparency when we look at realizing operational effectiveness. So again, I gave you some statistical data that's real, that's live, and also introducing near-term implementation costs. We want to make sure that incrementally we look at this as near-term implementation. So, some folks would recognize it as a project versus a program and vice versa. This is ongoing. It's ever flowing. It's continuing. That's where the change management process comes into play. When we talk about what does that look like, and having those voices echo and author some of these changes. So again, authoring the newest implementation guides and sitting down with the industry and making the real world examples and use cases. Again, we want to make sure collectively that everyone is together in making decisions. Importantly, understanding implementing X12 8060 is not driven by the need for new or greenfield infrastructure, but rather enhancing to more modern and scalability of transactions. And again, making sure that information is readily available. It keeps up with the newest and latest requirements from our CMS partners, and making sure that we have the level of information needed to offer the industry what is best in class, best in business. Benefits and value, super important. Real world benefits and value. Super engaging, first of all, optimize the use of existing infrastructure. This is not tech debt. This is taking infrastructure build that is currently existing, that's working well, and moving data at rapid speeds, really engaging the industry. Operational effectiveness, as I stated just the previous slide, making sure that that information is continuing to evolve and sunset some of the older versions of the transactions and bringing that more modern, that consolidated landscape into the complexity that we have. Again, keeping information going, moving faster, quicker, more accurately, standardizing the information with completeness. And again, consistency is the key. And having voices to drive the data standardization and the completeness and the complexity of some of the data information that is currently in the newer version. Again, exchanging that level of information to where it's interpreted and can be parsed in ways that can explain to a health plan, payer, provider, vendor, and reducing any type of downstream rework. Super important. Engagement, interoperability, and really driving innovation, being that thought leader and driving to the next level of federal regulatory requirements and building upon the infrastructure that we have in place today. Because again, we're all transacting levels of information. Patient and provider experience improvements, another super win-win-win for everyone in the industry, because the partnership, the relationship, having the eligibility and benefits available when an inquiry is needed. Faster approvals on, authorizations, referrals, notifications, certifications that are incorporated in the 278 transaction today and what is used today. So with that, we lead into the return on the investment with the implementation considerations. A couple of things, recommendation would be to look at, from an industry perspective, an actual time frame that is beneficial for everyone to implement. Let me give you an example. July 1st or October 1st seem to be the really good times for CMS and team to really look at implementations. One, you've got, you don't want to do fourth quarter of every calendar year because that does have additional complexities for even Department of Insurance for some state laws that are coming into play as of January 1st of the following year. We also want to make sure we're not doing implementations at the first of every year. Eligibility and benefits. We also have claims, timely filing. And so again, we want to avoid the fourth quarter and first quarter of every calendar year for implementation. So our recommendation is to really look at either July 1st timeframe or October 1st. Operational changes and making sure from a change management, keeping that training and that process continual, making it available for everyone to join is super engaging for not just providers, but health plans, payers, our CMS partners, our Department of Insurance partners, our state partners, and engaging in education that is specific to the transition of information in the 8060 version or the next version. So again, there's a pattern here. We want to make sure timeliness, we want to make sure readiness, we want to make sure training is available and for everyone, and making sure that the time frame, once it's established, having a 24-month period of time for implementation seems to resonate with majority of our health plan payers at Availity. And again, wanted to list that as an option for an opportunity to suggest what we're seeing and what we're hearing. Keeping in mind for the small, mid-sized providers, we need to make sure that we continue to work with them to reduce burden, to make sure they have the support that they need, not only from an education, but from a technology perspective, whether it be testing, validation, regression testing, super important there, because you don't ever want to have an implementation without regression testing. So again, the recommendation would be to continue moving in that direction and keeping our small to mid-sized providers in mind as we move forward. Also, overall assessment, two main categories, transition and the long-term benefits. We believe that planning, thoughtful planning, making sure we have a designated time frame, looking at that time frame and making sure it's not fourth quarter or first quarter of a calendar year. And also looking at making sure that there isn't other implementations, federal regulatory implementations that are needed, but wanting to make sure that thought leadership and those subject matter experts are engaged with these transactions, transitions, because again, it's those folks that really, at the end of the day, make the process very smooth and, again, fully invested. Investment, budgeting annually as a regular line item. We all do this in our budgets. So want to make sure that we continue to include, from an investment perspective, transition, a budget that includes a regular line item for enhancements, transitions, and then again, all the added value will come and that investment will be realized. Collection and collaboration across the entire industry, not just talking just providers or health plans or clearinghouses and vendors, but engaging everyone, including the entity, specifically X12 in those testing real world scenarios, regression testing, and continual regulatory review, insight feedback as to what is working well. Best practices, establish that so that what is working well, we can establish that feedback during the comment period. Long-term benefits, reduce fragmentation. Again, super important to do that. I know in the industry today, there are folks that, have a different definition of this term, but I think we all can agree that it is important for us to continue to reduce costs, reduce burden, and come together with a recommendation that we all could implement and timely. Improve
Michelle,
data quality again. I know I've said
if
this
you
more.
could,
Yep,
if you could wrap up fairly quickly, we'd appreciate it. Thank you.
absolutely. Just improve data quality, improve patient data exchanges, and patient quality outcomes. And that was it. Thank you.
I appreciate that very much. And again, thank you to Jamie, Nick, Pam, and Michelle. And with that, we will move to our final panel. But I just wanted to remind folks that following the next panel, we'll have an open opportunity for attendees to offer their thoughts, perspectives, and recommendations. And with that, I'm going to turn it over to Pam to be our moderator and introduce the final panel.
Thanks, Rob. Our final panel is a series of other types of stakeholders that are presenting their perspective as well. So we have Michael Phillips from CAQH, Kevin Day with Edifex, a Cotivity business, and Chuck Vaverka, who's a senior consultant with Coons, Lee and Associates. So Michael, I will turn it over to you first.
Thank you so much, Pam, and to everyone involved today. I am just going to share my screen quickly. I think I am. All right. Just a quick confirmation. Everyone can see my screen okay?
Perfect.
Yes.
All right, perfect. So again, my name is Mike Phillips. I'm the Director of Advisory and Insights at CAQH. At CAQH, the focus is on powering a more connected and efficient healthcare system through trusted data. We work across the healthcare ecosystem to enable better data exchange, reduce administrative complexity, and support more streamlined end-to-end workflows. This approach helps reduce industry costs by improving automation and efficiency, while also keeping care at the center by simplifying the business side of healthcare by enabling more accurate and timely data sharing. CAQH supports more effective operations such as credentialing, directory management, and coordination of benefits. Importantly, this work also produces visibility into how administrative processes are performing in practice, offering a data-driven perspective on where industry is making progress and where opportunities remain. So kicking off here, progress is clear, but value is not yet fully realized. So let me break this out a little bit. According to the 2025 CAQH Index, the industry continues to make meaningful progress as the medical industry avoided approximately $251 billion in administrative costs, and the dental industry avoided approximately $7 billion, bringing the total to $258 billion in costs avoided through standardization, automation, and electronic transactions. That reflects decades of collective effort across the industry. At the same time, the CAQH index is clear that high adoption does not always translate to fully efficient workflows, and that distinction is important as we advance this discussion today. Take eligibility and benefit verification. At 96% electronic adoption among medical plans, it is one of the most widely adopted transactions. Yet gaps in data completeness, consistency, and integration continue to create measurable friction. When eligibility is fully automated, medical providers save about 13 minutes per transaction, which translates to an estimated $9 billion in remaining annual savings opportunities for medical providers. In other words, high adoption has not yet resulted in fully realized value. Claim submission tells a similar story. Medical plan adoption is the highest among the transactions we measure at CAQH, and it sits at about 98%. Still, there are approximately 7 minutes saved per transaction when fully automated, with $4.6 billion in remaining savings opportunities for medical providers. The infrastructure is in place, but the efficiency gaps remain. Prior authorization presents a different picture. Fully electronic adoption among medical plans reached 40% in 2024, representing the largest year-over-year increase of any workflow tracked. That is encouraging progress, but it also means the majority of transactions still involve manual touch points. The data reflects that reality. Full automation can save medical providers about 15 minutes per transaction, with an estimated 363 million in remaining savings opportunities for providers. Attachments remain the most significant gap, and notwithstanding recent federal proposed regulation, just going on into my statistics here, with adoption of 24% for medical plans. This has direct implications for workflows that depend on documentation, particularly claims and prior authorization. When attachments are not electronic, manual workflows persist and limit the efficiency gains achieved elsewhere. Across all transaction types, the CAQH index estimates approximately $21 billion in remaining annual savings opportunity. The challenge is not the absence of infrastructure, rather partial automation, uneven adoption, and disconnected workflows continue to limit efficiency. And some of those limitations are tied to the constraints of X12 version 5010 standard. Since version 5010, X12 standards have continued to evolve to better support the level of detail, specificity, and interoperability required in today's administrative workflows. That evolution matters because many of the inefficiencies reflected are not simply about whether a transaction is electronic, but whether the underlying data supports complete, accurate, and connected workflows across systems and stakeholders. In eligibility and benefits, newer standards expand support for service type codes, improved reporting for tiered benefit structures, and introduce more detailed information related to prior authorization requirements. These enhancements can improve how benefit information is conveyed and acted on at the point of care, particularly around coverage, patient responsibility, and pre-service requirements. In prior authorization workflows, updated standards support more detailed status information, along with additional clinical and demographic data. This creates the potential for clearer communication and may help reduce manual follow-up, repeated outreach, and administrative rework. For claims and attachments, the progression since version 5010 includes stronger linkage between claims and supporting documentation, expanded support for service-level prior authorization referrals, increased diagnosis capacity, and improved handling of adjustments. These updates better align with current billing practices, coordination of benefits, as well as value-based payment models. More broadly, there has been an effort to improve consistency across the standards, including aligned field structures and the integration of certain operating rule requirements directly into the technical specifications. For organizations already aligned with the development of these requirements, this may support a more integrated implementation path. And taken together, these updates reflect an effort to strengthen the structure, clarity, and usability of administrative data so that transactions can better support real-world workflows. This helps justify and support practical considerations of implementation, like the necessary capital investments to facilitate system updates, trading partner coordination, testing, as well as workflow changes. The CAQH index helps frame why that discussion matters. The opportunity is not only in adopting updated standards, but in how effectively those standards are implemented across the full workflow so that operational value can be realized. In closing, the data points to both meaningful progress and clear remaining opportunities. The next phase will depend on how consistently these capabilities are implemented, how broadly they are adopted, and how effectively they are integrated into day-to-day operations. I appreciate everyone's time, and thank you.
Thanks, Michael. And now I will turn it over to Kevin.
Great. Thanks, Pam. Again, good afternoon, everybody. I'll be brief. I want to say thanks again for WEDI for setting this up. My name is Kevin Day. I'm a principal business advisor at Cotiviti, having previously worked at EdFX for over 20 years, assisting over 100 commercial health plans and dozens of state Medicaid programs architect and implementing their EDI systems and supporting compliance to the HIPAA transaction set specifications, as well as their own business requirements. Today's FPC is concerning a topic of great interest to the entirety of the U.S. healthcare system, one in which help advance the healthcare ecosystem, but which also comes at a cost. My comments today address both aspects. EdFX, as most of you know, have been providing U.S. payers HIPAA compliance services for over 25 years. Our HIPAA validation service, X Engine, is used by hundreds of payers to ensure their core systems adhere to HIPAA implementation guides. This includes dozens of state Medicaid agencies and participation in CMS administer programs such as their asset program mentioned earlier. Addition to that, our HIPAA validation engine is also used by a number of intermediaries, including within the healthcare ecosystem, including Availity, which was previously in the intermediary panel. All to say is that when U.S. payers community was previously faced with the need to upgrade their core systems to support the HIPAA X12 5010 transaction sets, EDIFX developed and implemented a HIPAA transaction mitigation solution to support those organizations during that transition period. The solution enabled payers receiving inbound 5010 versions of all their HIPAA transactions the ability to translate those transactions to the 4010 release level for internal consumption while preserving the original submission. The outbound response transactions produced by their core systems in 4010 would be up-translated back to the 5010 format, supplemented with original inbound data elements where needed. By implementing our core system HIPAA upgrade mitigation solution, payers were able to modernize elements of their core systems, including their claim adjudication functions, on a timeline consistent with the compliance date set by CMS and beyond. With respect to the current upgrade path being considered 5010 to 8060, cost again is at the forefront of payers' minds and concerns. Cotiviti believes that a similar operational approach can be applied. The benefits of this approach would allow health plans to modernize their core systems at a pace in which they can optimally follow. Further, we believe that health plans, once their core systems are modernized or supported through a solution such as the one I described to support the 8060 transactions, will be enabled to more cost effectively integrate those systems with several standard FHIR APIs, reducing overall modernization costs. The 8060 version of the HIPAA transactions is, as many have noted, more expressive and has greater data richness. We predict health plans that implement the common HL7 DaVinci IGs would see on average a meaningful reduction in cost to integrate their core systems by approximately 30%. One such example of note would involve the workflows related to the No Surprises Act and the requirement to produce an advanced EOB. Currently, as stated during CMS policy listening sessions during 2024 on the subject which I attended, it was stated by health plan representatives that many of the health plans utilize their current claims adjudication system to produce an AEOB by way of creating a fictitious 837 and representing the 835 produced as an AEOB. However, there were issues with this approach, which was addressed in the 8020 version of X12 with the addition of the X370 good faith estimate transaction. Although it's not a named HIPAA transaction, a core claim system which upgrades to supporting 8060 could more easily adopt that transaction, which aligns more accurately with the PCT FHIR structure, reducing the overall cost of implementing the PCT-IG integration. In summary, we advise CMS to proceed with the adoption of the 8060 version of the X12N transactions as named HIPAA transaction set. We believe that the benefits to the industry outweigh the cost and have demonstrated the means by which payers are able to remediate the speed at which their core systems can support the updated versions. Thank you for your time today and welcome any questions.
Thanks, Kevin. And now we'll move on to Chuck.
Thank you, Pam. I need to share my screen.
Chuck, you do have permissions to share your screen.
Is that coming across, folks?
Not yet.
Michael, can you bring up the screens for me, please, and hold on the first one?
Oh,
your screens are up.
We can
it
see
came
it
up.
now.
Yep.
Good afternoon. First, thanks to CMS and WEDI for sponsoring this event and providing an opportunity to comment on this major issue. Chuck Vaverka here. I'm a senior consultant with Quinsley & Associates. We're based in Okemos, Michigan. KLNA is a consulting and software development enterprise with 35 years experience in business and information technology solutions for both the private and public sectors. My comments are based on my own team's experience during the 5010 implementation, subsequent ICD-10 conversion, and ongoing partner data exchange testing for a large payer. We don't have enough time today to get into in-depth background, but I expect there will be lively dialogue on these and related topics as we all plan for and move towards 8060. I'm offering 3 items today. The first 2 actually build toward and simplify delivery of the third. Since it requires time and people, therefore resources, it involves cost for the actual 8060 implementation. Recommendations. First, migrate all HIPAA transactions to the 8060 standard on a single cutover date. Use a single HIPAA transaction standard after migration. And a payer should offer partners a B2B file format, syntax, test environment before implementation. In order to achieve this, CMS should include time in any schedule to encourage sufficient B2B testing duration before go live. First, migrate all HIPAA transactions on a single cutover date. This reduces administrative overhead posed by sequential projects for individual groups of HIPAA transactions. It ensures transaction version compatibility. It's going to encourage industry coordination under a single schedule, and it focuses each organization's internal efforts on a common goal. This is going to help bridge across internal functional silos. It will reduce multiple project and budget approval administration efforts, and it's going to encourage teamwork. We will all have the same target. Secondly, use a single HIPAA transaction standard after migration. This maintains version consistency for processing interaction between transactions. It establishes a common industry starting point for new X12 version cadence, and it reduces complexity and maintenance efforts for our individual organizations' business operation, EDI, and IT teams. Thirdly, payers should offer partners a B2B file format syntax test environment before implementation. This will have to start off with provider and payer contact re-verification. You would be surprised at how many times that contact information is missing. It requires careful planning for test and response file exchange using special file naming conventions because we do not want to commingle test and production data files. It provides an additional testing sandbox for any late adopters of recent transaction mandates. So at the point in time when I believe we would be doing 8060, we should have already completed the 278, 275, and 277 modifications that have been recently regulated. This activity will expose any file exchange or processing problems prior to go live, which allows us to fix them before we actually get into production on day 1. This approach has been used before, and it will significantly reduce problems during implementation. So I just want to say thank you, and I would also suggest that folks refer to the WEDI archives for information on the version 5010 and ICD-10 migrations. Again, my thanks.
Thanks, Chuck. And I will turn it back over to Rob.
Thank you, Pam. And big thanks to our final panel, and thanks to Michael, Kevin, and Chuck. And before we go to our open discussion, I just wanted to remind you that this is, again, a unique opportunity for you to share your perspectives. And all comments will be captured and included in our report. But as I said earlier, we do not attribute any comment, question, or recommendation to any individual or organization. And with that, I'm going to turn it back over to Denny and Pam to moderate our open discussion.
Thanks, Rob.
Thanks,
Just
Rob.
to remind, you do have the option of putting comments in the chat, or you can raise your hand to be unmuted and discuss your question or comment verbally.
And I think we've got a few slides to prime folks in terms of some issues and questions that they may want to address. I think we've got a first polling question to start off with.
And just a reminder for those who are considered co-hosts, please do not participate in the poll. We'll let it run for another 15 seconds. All right, ending poll, sharing results.
So, Pam, we have a pretty even distribution, except for those who are unfamiliar with the 8060 transactions, ranging from slightly familiar at 28%, which is shared by somewhat familiar, and then down to 16 and 15% for people who are familiar and very familiar, respectively, with the rules. So it looks like we have a pretty diverse audience.
And I think those results look really, really good, actually, but also emphasize the opportunity that we have between WEDI and X12 to help share information about the transaction and help raise those familiarity levels. So I would encourage everyone to go to x12.org and take a look at the slides that are available for the education sessions that have been done so far, and also take the opportunity to review WEDI's material that's been produced about the updated transactions.
And we have Teresa Autry with your, if I'm pronouncing your name properly, Teresa, with your hand raised.
Yes, thank you. I wanted to comment on the 8060 edition of the DTM segment and a comment that was made about the specific use case of that. The introduction of technology to allow people to stay home is huge. We commonly refer to that as the electronic visit verification. It allows patients to leave the hospital sooner and get home to where they recover more comfortably. But in order to make that work, we have to allow home visits multiple times a day. And currently, we can't do that in the 5010 version. We require the 8060 version in order to make that a visit at 8 a.m., a visit at noon, and a visit at 8 p.m. So when considering the cost association with 8060, it also needs to be balanced against the cost of those patients staying in an intensive care unit where they can get that kind of ongoing care. So it is not readily apparent, but my organization is particularly keen on reducing costs of patients in hospitals by sending them home where they're going to be happier and recover better. Thank you.
Thank you, Teresa. We got a couple of thumbs up for you, and we also got a comment from Kevin Day. Kevin or Eric Bryant or Diana Roof, do you have anything you'd like to say to second Teresa's comments?
Yeah, I do, Denny. So thanks for the opportunity. So I was just about ready to type back to her saying, yes, I absolutely agree with that. With the move in the industry to reduce cost, not only are they moving toward more outpatient services, they're actually moving many of the post-acute services to the home. So you're doing infusion services, so forth and so on. So there's a lot of more at-home services going on. And with that, the ecosystem needs to adjust to that. right? So how do we deal with the patients now receiving and service providers submitting claims in this type of environment? Where the system was set up when 4010 was first created was the makeup of the ecosystem was very different back then than it is now. It's evolved. And the 8060 provides the mechanisms to provide the list of electronic means to encapsulate that evolution. So I applaud Teresa's points.
Thank you, Kevin. We have another question from Joe Bell, who asks, if not now, then when? And what will additional time benefit and won't continued delay create additional challenges? Joe, do you want to add more to that or round your question out, or are you ready for us to take comments on that? And I see, Joe, you've added something else.
Yeah, I'm just, we've been in these discussions roundabout ways, change the 8060 to the standard that we've all been working on over the past 10 plus years. But again, if not now, when? And the longer we delay, is that going to create even more challenges, disruptions, et cetera, to adoption of any standard? What does the long-term roadmap look like? Because, Teresa's got a great point, but to have to do a whole new version to support that, what's next? How are we able to go along with this rollout or the process in order to meet ever-changing requirements?
Great question. Any comments from members of our audience in response to Joe's concerns?
I've got one, Danny, if I could. So
by all means, Kevin.
Yeah, I had a sidebar with somebody during this call about this exact subject, which is that health plans tend to have their IT staff domain oriented versus technology oriented. So in other words, it's the same group that's implementing the 278 transactions, or the same group that's also implementing the pass fire IG, right? So because of that they're domain specified, they tend to get into on conflicts when it comes to resource allocation in order to support these various regulations coming down from CMS. So I think that's sort of what Joe's getting at, which is, all right, how do we handle the number of the timing behind these regulations with limited IT staff, and how do you mitigate that? I don't want to speak for Joe, but that's my take on it.
All right, we have some raised hands. Just as a reminder from our host, Michael McNutt, if you want to be unmuted to speak, just raise your hand as Joe and Arna are doing, and we can then unmute your mic and let you take the questions. Joe, do you want to go first?
Sure, thank you. So just to comment on the last statement, this goes back to Pam's information from the perspective of the cooperative exchange and the rolling planned scheduled release of updates every 3 years. And her chart was blocked when she was talking, but it's something that could be adopted by the industry, and then it's not such a huge change. We make changes frequently when we're trying to keep up with policy or new programs, and we might institute the use of a segment that we didn't use before, or a data element that we didn't use before, and so we have to make those changes. But adopting that scheduled release of updates, 8060 to 80 next, or 90, whatever, in a planned and expected release cycle, then the changes are not so significant and can be, planned into a budget moving forward.
Thank you for those comments, Joe. Arna.
Yeah, I was coming to make similar remarks, and I just want to be clear, first and foremost, I am no longer representing the DECC as the DISMO, nor am I representing STEDI or WEDI in this commentary. But I think it would be remiss of me if I didn't point out that the way that we're structuring reimbursement policy should not be impacting access to care, and a deficiency of a way of transmitting that information between payers and providers is a constraint. And so, as the mechanisms and the policies that we have around reimbursement are evolving, we need a healthy standards ecosystem to keep up with those changes so that we can deliver care in what's the best way for the patients. And so all of this needs to be centered on what is best for our patients and the delivery of the care that suits them. And all of the work that we're doing should be in service of that end goal, regardless of how payment is remitted, regardless of how information is transmitted. I think we just have to keep that as our North Star.
Well said. Well said. Joe, turning back to you.
Yeah, and those are great comments, and I 100% agree with them. But those of you that know me, be surprised, we play a little devil's advocate. We've proven that our current course, based on historical reality, that by the time that a standard is ready to be released, goes through the approval process, and gets mandated, takes too long. And I don't hear anything about addressing changing those facts. And that's, to me, that's kind of what we need to address, is how does this become a sustainable process that organizations aren't bulking or not doing anything until it's mandated for them to do it. One of my suggestions would be perhaps government funds and resources might be used to build black box solutions or interoperability gateways that will be built to the specs that can be upgraded so that everybody is compliant, and we're just working on interfaces to that black box with our internal systems. There's various, there's probably a lot of other ideas that could be happen, but our current course and what was mandated back in the original HIPAA, although worked real well to get people on electronic transactions, we're dealing with a different goal and objective now.
Very good. Joe, do you have comments or thoughts in terms of how today is differing from 20 years ago or so is going to impact the rate at which and the speed at which 8060 will be adopted? at some point. Any thoughts from you on that? All right, turning it over to others. Let's see, we have some comments in the chat. Stanley, I see that you have a question in yours that says, let me make sure I can find it. Who should be responsible for doing the multiple requests for ROI, return on investment? It will be very different from entity to entity. Stanley, do you have some ideas or some hypotheses about how this particularly thorny issue might be resolved?
Yeah, thanks, Denny. It really would take some specific examples of people to move ahead and do a specific return on investment to serve as a guide for others. I mean, you're not going to be able to measure the ROI for every physician office or every health plan, but if we could get a couple of folks to sort of step forward and almost pilot test this, and present that return on investment, whether that's done after the proposed rule or final rule is published or before is an interesting question. We can only hypothesize, what's good and what's bad about the standards and make guesses about the costs. But until somebody actually goes through the process, you won't be able to do that. I think it's unfair to expect X12, for example, to do a benefit cost analysis because again the impact is so different from folks to folks. But if we can get some examples, that would be great. I'm not sure who would volunteer for that, but it would be nice to see some.
Thank you, Stanley. That's a great question.
And we do have a comment from Teresa in the chat stating it's an additional advantage for 8060 moving to external code sets. That there's so many more external code sets within 8060. And this means that the X12 standards can be more nimble. Today, the code sets are static because they're inside the implementation guides. Moving them externally means that we can introduce new identifiers quarterly and be more flexible and be more reactive to changes in the industry. So that's more of a comment than a question, but thank you, Teresa. And do you have any additional updates on that comment?
Sorry about that. No additional comments. Thank you.
Thanks.
We also have a good question from Kevin Day, which is how would the planned release be affected by the addition of FHIR IG operations as named HIPAA transactions? Kevin, do you want to elaborate on that question and then we can throw it out to the group for comments?
Sure, Denny. So I don't think it's a surprise to anybody that CMS has been looking at for some time now of adopting specific sets of the HIPAA or the FHIR-based IGs. Specifically, they were concentrating last fall on the prior auth of actually naming those versus having currently covered entities have to have an exception in order to utilize the FHIR-based approach for a prior authorization via FHIR. And it's my understanding that that they were looking at just naming that either the pass IG, I don't know the specifics behind it, but either the pass IG or its operations as named HIPAA covered operations. So if that's the case and they include that, now we're intertwining planning around HIPAA X12 transaction sets and FHIR-based transactions. And my point earlier then gets brought up again is that it is my experience that most health plans, at least, have IT staff that's domain specific. So whether or not you're working on a prior auth that's FHIR-based exchange or X12-based exchange, they're the prior auth staff. They're the eligibility staff. So anytime that there's an intertwining of technologies, the health plans then are strapped for resources if they overlap. And I guess that's where I was going with. I love the idea of the planned approach and saying, hey, let's do let's plan for every 3 months. Let's make this more nimble. That's a great idea if we were looking at only it being X12 or the code sets that are referenced by X12 transaction sets. But now that if we start looking at the fire-based work, and more so if they literally start looking at of adopting some of these fire IGs as named transactions, it's going to get even more complex. I think that's the growing concern, at least within the health plans that I speak with.
Thank you.
And Nick has a comment. If health plans fully implement X12, 8060, 270, 271 eligibility checks and use all of the new fields intended, then that will cut down on phone calls to check the details of patient benefits. And Arna replied, agreed, I would strongly encourage operating rules that mandate the inclusion of all the information in the 271 response. So Nick, I don't know if you want to expand on that, or Arna, expand on your response about operating rules.
Arna, go ahead if you like.
Yes. Am I opinionated about this or what? So, I mean, speaking on behalf of the dental community in particular, whilst this does impact all of medicine, the dental community has a high degree of need for the information that is remitted in a 271 response. And the inclusion of that information can't be optional. Any omission of eligibility data will drive administrative staff to a portal, to a phone call, to a fax back, which, I mean, goes against the spirit of exactly what we're trying to do here with the administrative burden reduction. So the way that this is handled traditionally is through the operating rules, unless we can't make things required in the TR3 because they're not always going to be there's going to be variance at a plan level, but to the extent that a plan has that information available and it's part of their policy structure, the operating rules, like if we could have operating rules that require the disclosure of that information in the electronic transaction, is the only way we're going to get off these sunk cost technologies of payer portals and other tertiary means of getting this information. Everybody wants this, and so as we're doing a build, it just makes sense that we have the supporting infrastructure both in the standard and the supplemental operating rules to mandate this disclosure, because we can't have forked workflows. We're spending so much time and money on this.
And Christopher, it looks like you had a reply as well. Worried that cutting back some of the usage of the 270, 271 as proposed in CMS 0062 will limit the benefits of some of the changes made in these transactions in 8060. Would you like to expound on that?
Well, sure. As I'd seen from the presentation X12 had made on the 270, 271, the increased information that was going to be able to be presented about referrals or prior authorizations was one of the great benefits of what they have done. And yet, from the little I've been able to get through on the CMS 0062, it seems to be that any potential usage of information having to do with prior authorization is going to get pulled out of that, which is like, well, that's one of the great things you're now going to be able to get from this. So just worried, depending upon how that all comes out, that could be just, we're not going to get all we that was put into the work for the to improve the 270, 271.
Can I address that a bit? This is Nick Radov again. And so I think there might be a little bit of a misunderstanding. There's in the CMS 0062 rule, there's really not much overlap between the HL7 fire, Da Vinci prior authorization burden reduction standards versus the X12 270 271. So you still need to do 270 271 to check patient eligibility. get all the benefits details, all the coverage stuff. The Da Vinci prior auth burden reduction is really focused on prior authorization. And so there is a slight bit of overlap in that, the 270, 271 will tell you at a very high level, potentially, whether prior auth is required or not for particular services. So there's a slight bit of overlap there with CRD, but really we should look at these as complementary standards that can be used together during an entire course of patient care.
Yeah, so but Nick, my concern was not that there's overlap, but that the way that at least it seemed to be in the proposed rule, that it said that you couldn't be using the 270, 271 for some information having to do with prior authorization or certain questions about that. And that's what I was worried about, just the way it's broadly written in the proposed regulation. And then, so therefore, what does that mean to an 8060 NPRM?
Yeah, I think that might be a misunderstanding, and maybe we should take that to a offline or to a different discussion. But I don't think there's anything in that rule which prohibits using 270, 271, in its entirety. You can continue to use it to check those patient benefits, including checking to see whether prior authorization is required for particular, STC or specific billing code.
It sounds like it might be a really good discussion item for our eligibility and benefits sub-work group to compare and contrast and discuss the two different rules and what overlap there might be. So that's a recommendation that I can make to the sub-work group as well.
Lisa Miller, you've raised your hand. Give us a moment. We'll let you unmute and share your question with us.
So,
Lisa, I think you're good to go.
I am. Yeah, I am. So I've been around for a long time, and I haven't been back in the standards world for a few years. Everybody that's been around for a long time knows who I am. So hi, guys, I'm back. I've spent the last 6 years working in behavioral health, and I do claims adjudication, cradle to grave. So bring the claims in. And just so everybody that doesn't know me, spent 20 years with X12 and quite a few years with WEDI. So hi, guys. How you doing? And we do real-time claims adjudication, 100% automated. So there's nothing that anybody has to do. We do value-based, inline, real-time. So we're real unusual. It's Medicaid-based. It is for behavioral health. So my providers are the poorest of the poor. This 8060 implementation is going to hit us hard. There's no doubt about it. The providers have almost no money for anything towards vendors. 5010 was a train wreck. I'm just going to say it for implementation. We have them stable. Everything works. We don't have workarounds. They're able to do amazing things. We have good quality data that goes back to our state. So I look at this, and now we're working in interoperability. We really want to do FHIR. We want to move forward and have this to be interoperability. Okay. So we're really interested in making sure that everything that we invest dollars into from an IT perspective is something that's going to have benefit for our providers at the end of the day. This is like a plea to standards development that everything we do makes sense for our provider community, because everything we do is to put care dollars back into our system. That's what we do. That's the goal of our system. Okay. So I come back to the table to put volunteer hours back in here to make things better. And I really loved what I heard earlier, which is every decision we make needs to be for care dollars. It's not about if it's X12 or it's HL7, it's about making the right decision for our providers across the industry at the end of the day. What's the best thing for them? And I think that's the most poignant thing. And I agree with Stanley. We've got to do ROI. We've got to look at, is this the best thing moving forward? Are we making the right decisions as an industry? Is this the right thing to do? You look at the legislation that's out there right now, and it looks like we have competing things going on, and we've got duality. It looks like CMS is trying to move us towards API and FHIR, and now we have X12, which is not API and FHIR enabled. So I'm going to say to everybody on this call, what are we doing? Are we doing mixed messages? And I heard Kevin Day, thank you very much. I heard what you were saying. Are we giving mixed messages? Are we giving vendors things just to implement, or are we doing the right thing as leaders of this industry? So I'm back. I'm here. I'm going to advocate for my providers because they're the poorest of the poor.
Thank you, Lisa. Kevin?
Well, thanks for the call out. Welcome back, Lisa. So
You're welcome, Kevin. Nice to hear you again. I know you well.
Yeah.
Yeah.
Yeah. So, geez, where do you start? So, yeah, and guess that's the whole point, right? Is that the industry is getting mixed messages from CMS to be very candid, right? They're pushing all of the FHIR regulations or adoption of FHIR, but then they come out with the claims attachment, right? Now they're talking about 80/60. And my point is that the health plan, I'll just speak for the health plan, that's who I deal with mainly, are sitting there saying, all right, which direction are we moving toward? Because we've got a limited set of IT staff. And again, they tend to be domain specific, right? Not technology stack specific. And we have to lay out all of these regulations with dates to say, how do these line up and how do I set up my project plans for the next 3 years, right? To be able to accomplish what I have to be, because my compliance office staff is going to be down my throat, making sure that we're meeting all the CMS compliance rules so we don't get audited, right? So I think that's one thing. I would also say this back to your point. To make matters worse, if you look at my advice to everybody is take a look at what CMS is doing themselves. They're the largest payer that there is in the U.S. realm, right? Between Medicare, Medicaid, all the payments, ACA with subs and all that. So they released an RFI, I think it was like January, then recently, like a month ago, an RFP called their core claims, or claims core RFP. And what that's all about is modernizing and consolidating I think it's 4 different payment systems, claim adjudication systems into a singular platform. And part of that, I was reading through it last week, and they want to move it toward modernization. That means they want to move toward real-time claims, submissions, adjudication, and payments. But it also means a bunch of upfront things such as fraud detection, so forth and so on, benefits checks. So they're pushing that toward this environment, and they're going to expect the rest of the payers within the US to follow suit. But how do you do that? Are we going to stick with X12 and then move X12 toward a real-time exchange? Is that what we're going to do? We're going to do real-time claims coming in via an 837P and 8060 into my adjudication system? And then, what does that mean for a service or a health system, a billing provider? I'm looking for the remittance. Am I expecting a remittance 30 seconds later? I mean, I guess that's where it's at. It's just, I think there's, generally speaking, then I'll shut up, some confusion on where CMS is wanting the health, at least the health plans to go. I won't speak for the health systems themselves.
Thank you, Kevin. Stanley.
Yeah, thanks. I don't think there's a conflict here at all. I mean, I think it is clear that with a lot of the clinical data that's being exchanged, um, the industry is attempting to move towards FHIR with for certain communications, and it looks like those transactions probably will work. We haven't had a lot of experience with a lot of them, but little by little, FHIR transactions are being implemented and are working in the situations with which they have been put. At this point, the X12 transactions are working in those for those transactions, the HIPAA transactions. They're working well in a very large scale. They are, and I think X12 has worked to enable real-time transactions for in any of the transactions, the claim and others. The problem is not with the exchange of information. The problem has always been the whether a health plan can actually do the necessary reconciliation and provide a real-time answer. But I did I would say there is no conflict. I'm not even sure there are mixed messages. We can be moving towards FHIR in certain situations. We can also be upgrading X12 in the appropriate situations. There's no real conflict here. So I we applaud CMS for putting out that RFP, whether they'll be able to accomplish real-time adjudication. And I think it does. The RFP does talk about using X12 transactions. Whether they'll be able to move towards real-time adjudication, we don't know. But I don't see conflicts or confusion here. The only confusion is that there are different transactions that may be required to be implemented at the same time. That's the little bit of conflict, but there's no problem using FHIR and X12 at the same time. Thanks.
Thank you, Stanley. Amy Kay.
Good afternoon, everyone. This has been great discussion so far, and thank you for taking my question here. A couple of things. I wanted to thank Kevin for his comments about what we're seeing in terms of all of these different standards going back and forth. I am not only a compliance resource working at a health plan payer, but I'm constantly getting questions about the conflicts, perceived conflicts of the messaging of HL7 and FHIR versus X12. So we're seeing some things that come out that, yes, we're absolutely going FHIR and going in this direction, but there's places where, okay, maybe a provider can continue to submit X12 if they want to. Then we have a new set of rules that come out that does say this is all going to be FHIR, and now it's going to be used FHIR for eligibility in this particular instance. This goes back to CMS 0062. Now we finally got the final rule for standards, and I'm assuming getting 275 adopted as a standard was necessary in order to, advance it going forward to eventually bring it into the suite of 8060 or beyond, because up until this point, we haven't had a defined standard for 275 attachment transactions. But what does that all mean? I'm getting pushback from our organization in terms of tell us where we need to put our budget. Do we have to dedicate this all now to APIs and FHIR standards because that's where the industry seems to be signaling that it's going for all transactions? But now we need to take a look at probably moving forward with 8060, again, without that kind of cost analysis. And what's around the corner. So what do we do with our limited budget? What do we do with perceived conflicting regulation and information that we're getting? And even on this call, we're hearing sort of a split of the kind of vendor community, clearinghouse community sort of being in support of moving 8060. But we're also kind of hearing on the provider side through the AMA and so forth. Well, maybe not, because you have to show us what what the real ROI investment and benefit of all of this is going to be. So just wanted to share those thoughts of, I'm kind of confused and also sort of looking for direction in all of this, but looking for real information that I can take back to, my enterprise stakeholders so that they can make some reasonable decisions of where they're going to put our limited budget and resource time and what we'll concentrate on. So with that, I'll stop. Thank you, everyone.
Very good points.
Rebecca made a comment in the chat that CMS mandates don't cover all payers and providers. We'll end up creating two systems of care that have to be sustained. There are entire segments with zero practical fire adoption. And Rebecca, I don't know if you have any additional comments there.
Sorry, had to find my unmute button. No, I think one of the things that we have to consider, right, is at least for the dental industry, we're looking at very low participation and depending on cuts and things like that, decreasing participation in CMS programs. 73% of dental offices are private small businesses, and we have real evidence of the business need to move to 80/60 now. I understand the need to move towards a fire maybe in the future, but I don't think it's and or. I think we have to meet people where they are now. So I guess that's my concern is if we, in the talking points, when we say, oh, we've seen what CMS has done or CMS providers and CMS as the biggest payer has done, that still leaves more than 50% of all dentistry out of those conversations. And I know dentistry is not the only one.
Thank you. And Kevin also added to the chat, let me clarify my message. I firmly agree with Stanley's statements. However, 57F was a litmus test for the industry, and that he mentioned to another attendee offline that I know of some health plans that have stated they are putting their development work on implementing 278s on hold.
All right, I'm going to come off mute. I'm sorry. So Stanley, I'll answer your question you just posted. He asked, well, he said, I don't know why. I'm assuming, Stanley, that's geared toward me. The reason why is, and I'm just going to say what I've been told, right, is that some of the health plans are reading the tea leaves, if you would, and they're anticipating CMS pushing more toward adopting fire as means for administrative functions. The 57F is administrative function. Prior authorization is an administrative function. It's an operations. It's not a clinical. There's clinical information involved, but it's an administrative function, right? It's a pre-adjudication of a claim. And the point being is that it was a litmus test in the industry by saying, if we can get the industry to adopt fire for the purposes of one of the most sought after pain points in the industry, affecting health systems, the providers, the payers, and more importantly, the patients. And I'm an advocate of that. I've been involved with prior auths not getting timely done. So believe me, I know that how important that is. But the point being is that they use that for a reason. Is because then there's no controversy on the importance of modernizing, reducing the burden across the board, and they use an administrative function. So if they do that for that one, the question is then, well, what's next? And specifically around the 278s, what they're saying is these health plans are saying, we're just not going to work on the 278s, all right, because we're just going to move purely to fire-based. And because the anticipation is that they're going to adopt the fire-based exchange for prior authorizations is HIPAA covered to eliminate the current situation, which is you need they're taking discretionary measures, right? That's how it's lined up in the Federal Registry now, right? It's not officially HIPAA, but they just did discretionary enforcement. So then the question is, if they're going to do that, then why would I implement a 278 based exchange? Right. And then the next question is, well, what administrative exchange of data is next on the list, I guess? Are we going to the point of earlier? Yes, the CRD is not the same thing as a 270, but who's to say that they don't decide to move in that direction too and move to a real-time fire-based exchange for eligibility checks? If that makes sense, Stanley.
We've also heard that in the 62P rule, proposed rule, that the fire implementation guides will go from being prior authorization implementation guides will go from being highly recommended to required. So we're seeing a stake in the ground when it comes to prior authorization. And with that comes the PA, the prior authorization support, the PA PAS, what we call PAS, and that's going to reduce the demand for 278s, especially as you point out, Kevin, people have been given enforcement discretion to use the PAS instead of the 278. So I think as we look at it now, and this is, one opinion and one opinion only, and I work in both the EDI and the fire worlds, but we don't see our health plans in our marketplace moving to aggressively adopt the 278. We find that the adoption, as was shared by CAQH, hovers around the 40 to 60% range, depending on who you talk to, unlike the other sort of more well-established transactions. And with PAS being a required IG for prior authorization, it seems that there's going to be further downward pressure, suppression on using the 278 for prior authorization. So that's what we see in the regulations. Obviously, we're all going to comment and we're all going to weigh in on that. But I think there's, as you point out, Kevin, this administration is leaning into fire, and they're leaning into finding places where fire can be implemented. But also, they recognize that, the wheels of commerce run on EDI and X12. And, I think for many of us, the discomfort is going to be living with, one leg in one camp and the other leg in the other for some period of time while the industry starts to resolve, how it wants to do these things going forward. But I fully suspect we'll see ourselves working on both simultaneously. Let's see. Pam, do you see anything you'd like to draw attention to?
Yeah, Marcia put a comment in the chat that as an employer that runs a health plan for our employees and their families, it will be very difficult to adopt 8060 because we're totally dependent on vendors, including clearinghouse, claims administration, and claims processing software, and payment fulfillment vendor. I don't think any of my vendors are attending this meeting, and I suspect that they would charge us a significant fee to do any of this work. I did spend 25 years with a very large clearinghouse and went through the 4010 to 5010 implementation. The biggest challenge then was getting the payers ready, and I believe that the payers' vendors are slow to participate and respond to these initiatives. Marcia did have to drop, but points out, I think, a very important point, which is the reliance on vendors from both ends of the spectrum: provider vendors, including EMR and EHR vendors, clearinghouses that sit in the middle, and then payers, business associates as well. I think that there's a significant dependence on vendors who are not specifically covered entities unless they're designated as a business associate. So there's challenges there as we have these dependencies for the vendors to become compliant and then work with their trading partners to then do testing, et cetera. That was, I can certainly speak to that was one of the challenges in the past update, was trying to complete end-to-end testing while some of the trading partners waited on their vendors to get them updated. So I see several other comments kind of coming in on that. There are several clearinghouses represented on this meeting, and I think that piece of the industry will be prepared to support 8060 in time for any deadline. And Arna says, I see business associates being a bigger gap for implementation. And Kevin stating that they were able to mitigate that situation now, as well as in 4010 to 5010. So I don't know if there's any other comments around the dependency on vendors or challenges there. Arna.
Yeah. I do see the business associates who aren't named as designated covered entities, but do play a huge part in administrative transactions, and namely, like non-certified EHRs, practice management softwares, ambulatory software that is used to collect administrative, clinical, and claims data and to prepare the case to be translated across to and clearinghouse and then receive that information. A lot of them don't have, even at the 5010 level, the structured data elements in their database to be able to post full scope response from payers. And so if they're not collecting that information, everything here has to be structured. We have to be able to collect information and transmit it through the full chain of custody and back. And if we can't collect those core data elements at the point of care, then we've got a massive gap. And so that's a big key to all of this. And it's something that needs to be addressed very early in the stage if a named standard is, if 8060 is named, we need our business associates to be aware of this and to start adding that information in, because I know in dentistry, we're still on server-based software. And so the development cycles for those are 3 to 6 months just to get a product out, and then another 6 months before it's considered stable. And that's 12 months of a 24-month implementation rollout. So they're crucial to this whole process.
Excellent points.
And Joe makes the comment that if the entire industry is moving forward, vendors will need to get on board to keep their business, which of course is true. But as Arna stated, we have previously seen vendors may be on board, but then there's an implementation schedule for that to roll out to all of their trading partners. So it's great. Your vendor may have an updated version, but number one, you may have to pay for that updated version, and you may or may not want to pay that fee. Or number two, you're all excited to get updated, but you're number 867 on the list, and your date is next year. So it definitely introduces some challenges.
And I'm just going to chime in again, not to mention the change management of workflow optimization that comes with trying to train an entire industry to collect a piece of information that was previously not collectible. Not an insignificant move.
Joe Steiner. Oh, you're giving a thumbs up. I thought your hand was raised, Joe. Sorry to call you out like that.
Nope, that's okay.
Yeah.
And Rebecca has another comment. Payer fire APIs don't meaningfully reduce burden unless providers can actually use them. From the provider perspective, the real obstacle isn't whether payers expose standardized APIs, it's whether practice management systems and EHR vendors build usable workflow and integrated tools to connect to them. So again, kind of the same point that bringing those vendors back into the mix and making sure they incorporate the new standards and that they are implementable at the providers is a key part of the entire process. Rebecca, I don't know if you have anything else to add on there.
Yeah, so the only other thing I would add on to there, and I'm going to say this as gently as I can, is the issue of monetization of the transmission method. The cost on what is a HIPAA mandated transaction versus what will be perceived if it's not HIPAA mandated transaction and as an add-on service, that's where it's going to hit providers doubly, because we will see the cost of our technical solutions go up no matter which way they go. But if it's an add-on service, because it's not HIPAA mandated, we're going to be paying for that again, is the way I see it.
And Nick just put a comment in. Some clearinghouses may automatically upgrade or downgrade X12 transaction versions in flight in order to accommodate provider legacy systems that haven't upgraded to 8060 yet. That was a common value-added service during the previous upgrade from 4010 to 5010. And yes, I agree. I think that's really part of the functionality of clearinghouses. Technically in HIPAA, it's stated as non-standard version to standard version, but we did see that very prevalent during the previous upgrade in up converting and down converting to facilitate the varying stages of readiness that different trading partners have. Nancy.
I know that the conversation here has been very broad, not necessarily specific to the points that are on the screen, but I wondered, there are two other slides that have some other ideas for discussion points. I just want to make sure that we, give people some other thoughts as to points to bring up before we close out.
And it does look like we have about 5 more minutes. Arna made a comment, will we need a similar SNP edits framework or group for 8060 versions, and specifically the step-up, step-down timelines? And Kevin responded, correct, the SNP edits will need to be updated.
Kevin also adds, I'm surprised I haven't heard much about the benefits of social determinants of health programs and that the upgrade would assist. Kevin, could you elaborate on that?
Sure. So basically, I think it was starting with 80/20, and I don't have the specs in front of me, but there were additional attributes added. I know there were changes to the 834 that dealt with collecting more demographic information that could feed into your SDOH programs, and I think and then the claims themselves that they expanded, that there were, and again, I don't have it in front of me, but I recall reading an analysis that dealt with some social determinants of health programs that the additional attributes associated with the patient would feed into. And again, I don't have them in front of me, but I know that was a big talk. Because the release level of X12 has to basically correlate to the US CDI, right? Because that's the overriding data set the industry works off of. So then the question is, all right, well, what US CDI version does the 8060 map to? Because that's where the intersection between, to me personally, the intersection between FHIR and X12 comes into play. So the common denominator is the US EDI. And specifically around social determinants of health, with the updated versions, they added a bunch of attributes around member or patient demographics that could be then be encapsulated during enrollment during the 834. So then we can then, put them into some kind of an SDOH program due to knowledge that we have around living conditions or whatever types of SDOH aspects that were encapsulated during enrollment. I guess it was I getting to, if that makes sense.
It does. Thank you.
And Jamie mentions that the SDOH use case was mentioned yesterday in the X12837 presentation in regards to more diagnosis and procedure codes. And Jamie, I don't know if you want to expound on that.
Yeah, just that, as was mentioned, that the potential use case of social determinant of health and the ability or the need to capture more diagnosis codes and procedures for the patients. That was something that was part of the analysis when the diagnosis codes were increased. And I forget where, if it was 80/40 or whatever, but it is in 80/60 that you can now send like up to 99 diagnosis codes in many cases.
Thank you. And Stanley asked a question that might be a good one for discussion for maybe our last question. Do you think it would be valuable for WEDI to develop an overall industry timeline for step-by-step implementation? For example, analysis, system development, internal testing, external testing, etc. Any thoughts on that? Rob.
Yeah, I'll just say that that's something that WEDI took on as a task through our, you've heard the term SNP used, Strategic National Implementation Process. I could see us doing exactly what Stanley is suggesting. I think there's going to be a need, not only the timeline and step-by-step with 80/60, but also maybe building in some of the other federal mandates and timelines there as well. So good thought, Stanley.
Yeah, and Rob, I think I'm unmuted here. Not only would it be a good guide for the industry, but if there's a set deadline, we can measure industry progress against that set deadline and at least give CMS some feedback about how well the industry is meeting, the step by step and whether we're really going to be ready for the implementation date.
Yeah, completely agree. And as we're doing now with the 0057 rule, doing a survey every few months to gauge where the industry is, I think is critical.
Arna.
Hi. Again, just prefacing this that I'm not representing the Dental Education Content Committee, nor am I like WEDI, because what I'm about to say is in conflict with someone else's comments earlier today in regards to the recommendation that this advancement of a standard wait until other timelines have passed. And whilst I am very passionate about the dental industry, I just want to highlight the need for this to harmonize our claim form back to the standard, and we cannot wait until 2028 to explore a standard. If we're going to name a new standard and have the EDI, have our EDI transactions matching our claim form, we are going. It's an uncomfortable thing we're going to be sitting with, but as an industry, there is a need for us to be sitting with multiple implementation timelines, and I think that's where WEDI could really be beneficial to sort of help structure all of these rollouts simultaneously. And then I do have a question that may not be appropriate just yet around now that the 275 and the 277 are named under the HIPAA mandated transactions, will they be included in version upgrades? I am lacking clarity around that, but that's something that I don't need answered today.
Well, I think we've reached the end of our time here. So thank you all very much for the great discussion. And Denny, I don't know if you have any closing comments as well.
None, Pam. Thank you.
So I think it's time to turn it back over to Rob to close out our session.
Thank you, Pam. Thank you, Denny, and thank you for the very lively discussion. We were worried that we may not get enough folks to share their opinions, but it was great, both in the chat and live. So thank you all for that. Just Michael, if you can go to the keep going, one more slide. Keep going. There we go. So I want to remind you all that the live event was just one way that you can share your opinions on version 8060. I strongly encourage you to fill out the survey. We're going to keep it open for a couple of more days along with the written statement submission form. We are going to capture everything that was said, both in the chat and orally. And again, we do not attribute any comment to any specific individual or organization. So you just know that we were going to compile a summary of all of the comments and provide that in a report form to CMS. Next slide. I'll make a plug for some of our upcoming events, including our spring conference coming up from May 11th to the 14th. And in particular, I wanted to highlight that the first day we're going to have an open forum where a number of our work groups, sub-work groups, and task groups will be meeting. It's open to all in the industry. It's a chance for you all to get a sense of what we discuss, and you got a sense here that we are a passionate group that are seeking to develop and implement standards to help the industry reduce costs and improve the delivery of care. So I encourage you to get involved in that. For WEDI members, coming up on the 19th of May, we're going to spend 3 hours talking about the 0062 interoperability and prior auth and drug prior auth proposed rule. And through that discussion, it will drive the WEDI comment letter, which will go back to CMS. Next slide. I think that's probably it. But I just wanted to take 2 minutes before we end to thank a few folks, because there's a lot of work that goes on behind the scenes. I first wanted to thank our partners at CMS, not just Michael and Chris for their work today, but we've got a wonderful partnership with the entire National Standards Group team. And I just want to thank them for their collaboration on this FPC process. I wanted to thank X12, in particular Andrew, for presenting earlier today on version 8060. To our moderators, Denny, Pam, and Nancy, thank you for keeping the discussion going. To our presenters, and of course, you all attendees, phenomenal feedback on this important potential change. And behind the scenes, big thanks to WEDI's staff, Nancy Spector, for her phenomenal job in identifying and communicating with all of the presenters. And she'll be the primary author of the report coming up. And of course, behind the scenes, our own Michael McNutt. Thank you so much for making sure the trains always run on time. So with that, I will thank you all and look forward to seeing you at future WEDI events. Take good care.